Dr. Herman.
Yeah.
I always found breath work to be such an incredible form of meditation, and that was honestly a great start to our day here.
Yeah.
Um,
I hope you
just
guys.
for the people tuning in now, I just wanted to reintroduce you, read a little bit about you,
Sure.
just so everybody has an idea of who you are and where you come from. So, Dr. Sara Herman is the founder of Soft Reboot Wellness. After majoring in human biology at Stanford University, she studied and trained in cardiothoracic anesthesia at Harvard Medical School and Columbia University. Sarah's personal experience with mental health undergoing breast cancer therapy in 2017 inspired her to shift her focus from operating room medicine to psychedelic healing. She has additional training in psychedelic assisted therapy and integrative healing from the California Institute of Integral Studies, Dr. Phil Wolfson, and the Ketamine Training Center, the Integrative Psychiatry Institute, and the Academy of Integrative Medicine, Health and Medicine. So, Dr. Sara Herman, you have the floor once again.
All right, cool. Hey, again, thank you so much for inviting me to speak today. And I hope that a lot of you were able to really get into that deep mindset that Maddie really invited with her meditation and breath work, because it's quite special when you can get to that place without using any substances and or medicines, and really just using your breath to get deep as a deep dive into self, which kind of, as I mentioned before, is a mirror for the psychedelic medicine culture in general. Psychedelic medicine really is a mindset. It's a philosophy. It's a collection of values. It's almost like a worldview, if you will. And the idea is really two things. We possess an inner healer, which allows innate power for each person to heal herself or himself. And this inner healer has the capacity to heal the body, the mind, and the spirit. So the goal of psychedelic medicine treatment is really to remove barriers and empower this innate ability to heal ourselves. The other idea that psychedelic medicine carries with it is that the medicines themselves are really just tools or catalysts to allow for this inner healing process. This ability to trigger transformation and enhance our personal journey of discovery work through biochemical pathways really can allow facilitation of this inner process and support a deep healing if we turn the experience inward. And this kind of goes along in my practice. When I first meet a person or client, I introduce myself as Sara. I don't go by Dr. Herman, because honestly, like, I'm not the doctor giving the patient the medicine. I am a person that is there to really facilitate a safe container for the person to do a deep dive into self in order to heal themselves. And that's where you really get these longer lasting effects, rather than people relying on coming to a physician to give them a drug to cure them. Research into the psychedelics began really a long time ago in the 50s, 60s, 70s, and it became more of a politicized movement when Nixon banned and demonized them. And so it's been, a lot of underground work happening during a 40-year really research hiatus. And then as we've come into today's time, there's organizations such as MAPS, which is the Multidisciplinary Association of Psychedelic Studies, that's really making headway in terms of research and getting psychedelics and psychedelic healing really back into, more mainstream activities. There's lots of governmental action that's leaning towards, decriminalizing and encouraging psychedelic healing, leading the way with Oregon. And, lots of cities all over the place have decriminalized psilocybin and are working towards decriminalizing even more, psychedelic medicines. So as we talk about, the psychedelic healing space, whether you get it during the brief exercise that we did, or for some lucky few, I mean, you really may have gotten deep there. But difficult. This is really difficult for most people to do. So you can think of psychedelic medicine as really a fast track to that inner healing space. Now, this slide kind of discusses the high incidence of depression even before the COVID pandemic, and the disappointing outcomes really of traditional antidepressants, and because of their marginal effectiveness and high incidence of side effects that really make long-term use problematic even for willing patients. So we're really looking for, or people are really looking, honestly, for alternate healing pathways. And again, this is just really looking at, in the first year of the pandemic, the jump in depression and anxiety, 30% really. And the issue with the pandemic and lack of social support and really other coping mechanisms have become really highlighted. And it's unclear really when the peak of the mental health crisis that's going to be seen from the COVID pandemic is really going to show its face. So, the Surgeon General in December of 2021 even posted an advisory on youth mental health crisis further exposed by COVID-19 pandemic. So it's really going to be a crisis that you will definitely see and probably have already seen during your med school training, honestly. So now we'll focus more on my favorite for the moment, ketamine. It's the only official legal psychedelic at this time. Technically, I guess it's not really a psychedelic, and it's more of a dissociative anesthetic, but it can achieve the psychedelic state that we're looking for in order to encourage that deep dive and inner healing. Ketamine was developed in 1964 as a safer alternative anesthetic, really to PCP. That's what they were using. PCP had a lot of delirium associated when patients were coming out of surgery. So they were looking for something that had less delirium and a better safety profile in terms of blood pressure and heart rate than these other early anesthetics. And they found it in ketamine. And, we've been using ketamine in the emergency and operating room settings, both as sedation for small procedures, really. Pediatrics, it's safe in babies through 100-year-olds with multiple medical problems. So the safety profile is really quite fantastic. And we still use it daily as an adjunct to multimodal pain regimens for patients having operations. It also still is used in active combat situations where soldiers have endured really horrible traumas and need sedation for procedures, but don't want alterations in hemodynamics. So ketamine is super safe, been using it forever, and it's a medicine I trust, obviously, very immensely. Now, since the year 2000, when the first randomized controlled trials of ketamine for depression came around, we've been starting to use it in mental health capacity. So for patients with depression, anxiety, post-traumatic stress disorder, OCD, and other chronic pain conditions. Although it's used off-label for all of these indications because it is FDA approved only as an anesthesia medicine. So anything that's not used as an anesthesia medicine is going to be used off-label. And essentially what that means is because the patent has expired, it is not financially beneficial for big drug companies to run randomized controlled trials to get it FDA approved for the mental health indications. Johnson & Johnson basically took one part of the generic ketamine, which is the esketamine, and turned it into a nasal spray. And FDA did approve that for treatment-resistant depression and suicidal ideation. So the FDA also is giving a nod to the benefits of ketamine for mental health and depression, but because there's no official big randomized controlled trials, it won't be FDA approved anytime soon. This is really a snapshot of the synaptic interactions at the neuronal level. As far as ketamine's mechanism of action is complicated, and it works on many different systems. So the main and most well-known mechanism of ketamine is as an antagonist or a blocker of these NMDA receptors, which are found really all over the brain and the spinal cord. This blockade leads to increased glutamate in the synapse, which is an activating neurotransmitter, and ultimately leads to a downstream protein cascade that causes a rise in brain-derived neurotrophic factor, or BDNF, and mTOR. Now, these proteins are really important because they're responsible for an increase in synaptogenesis and brain plasticity. So basically, you're getting new connections between neurons that probably wouldn't have crosstalk before, and you're getting healing of some damaged neurons. And this is really what ketamine therapy is needing and relying on, and a lot of these other psychedelic medicines as well. The brain plasticity, while you're getting a boost in mood from the glutamate, you're also making new brain pathways, and so you're able to really get yourself out of the same brain circuitry that causes you to think down on yourself, or whatever the issue is. This rewiring or new connections is really helpful for changing long-lasting effects. There's a researcher in the UK by the name of Robin Carhart-Harris who describes psychedelics. Specifically, he's talking about psilocybin as kind of like a snow globe, and you get, when you shake up a snow globe, you get all the little snowflakes to kind of land and cover the land with, a flat surface. And that's really this rewiring or neurogenesis, where you're getting the ability to create, new runs down a ski hill, or new brain pathways to think in a new way. Another really important mechanism in the way that ketamine helps depression and other mood disorders is this idea of the default mode network. And it's probably, I don't know if they spoke about it yesterday, but essentially this default mode network are communication patterns between various parts of the brain that integrate areas that are managing language, speech, emotion, and memory. This ultimately serves as the basis of your internal monologue, or that inner voice. Now, fMRI studies have helped to elucidate that ketamine and other psychedelics, and even meditation and breath work, are able to loosen this default mode network to allow a higher entropy state. And this high entropy state is really conducive to creative thinking, as opposed to the low energy or rigid state, which is seen in patients who struggle with addiction, OCD, and depression. Now, when ketamine is able to kind of serve as an off-ramp from those inner monologues that are just going around and around in the negative self-thinking, you're able to see that these areas of the brain are not lit up, which is pretty awesome. Now, this slide is just a complicated way to say that the potential therapeutic effects manifest themselves in 3 levels of processing. So the first is the emotional processing. Then there's a social processing, and the most important, again, is the self-processing. So a lot of folks with mental health struggles are really having negative self-talk. And so you're getting connection between all of these different levels of processing. And really the take-home message is that the cumulative effect of the processing between emotions, social, and self, and the way that ketamine is able to really cut that run around in circles is why, or really, let me change that. The reason why that these are all interconnected shows that there's a compounding effect. When you change one, you're able to change multiple different ways of thinking, and that's why you get such a larger benefit from ketamine and psychedelics than you would expect just from the neuronal mechanisms and the neurotransmitter exchanges in synapses alone. So now, as far as you know, pharmacokinetics of ketamine, and there's a bazillion ways to give ketamine, and they all have their advantages and disadvantages. In my practice, I mostly use IV ketamine, and this is because, number one, you have complete control over the medicine when it's given intravenously. I can, titrate to effect in real time, and the bioavailability is just about 100%. Intramuscular is probably more like 97, not so much 90. And then intranasal, sublingual, and oral routes of administration really depend on the patient's milieu. So their position, how long they can hold the medicine in their nose and their mouth before they swallow it. And so there's just a lot of other factors that go into administering the ketamine by other than IV. And honestly, once you get good enough, you can really, how to manipulate the pharmacokinetics in order to achieve the blood brain level, because that's really what you're looking for. You just want, it's all the same ketamine, you just need to get it to the brain in order to make it work. So now we'll kind of go into what it looks like when you come to my practice. And honestly, the first part is, patients are going to come looking for ketamine. They find me either because of a New York Times article, or they Googled me, or they got a referral from a psychiatrist or a friend. And the most important thing to know is, even though and Jesse and I were kind of talking about this before the talk started, but it's really easy to get into the excitement and think that everyone can benefit from psychedelics and ketamine, and it is really exciting and really cool, but honestly, not everyone's a nail, and so you shouldn't be hammering everyone into the pegboard. And so it's really important to do a detailed physical and medical and psychiatric history, and really figure out if someone is a candidate before they start their ketamine therapy. So as part of the workup, it really is important to have each patient's regular mental health provider, whether that includes a psychiatrist and a psychotherapist, or whoever they use as their mental health provider. It's really important to have them involved. So as different emotions and feelings come up during a series of ketamine, they have additional support holding them up, supporting them through the experience. And so everyone has to be on board. The other thing I really make a point of is looking at, and this is probably you guys, is looking at integrative factors and determinants of health, like before you decide that they have exhausted all of their efforts in fixing. So it's really important to think about diet, exercise, sleep quality, their support structure. You're not just, okay, we're human, we can give you ketamine type of thinking. I do like to look at labs, because there are frequently medical problems that contribute to mood and anxiety. So, I look at thyroid function, we look at, anemia, vitamins and minerals. I want to know what supplements they're taking. And a really important thing to think about is obstructive sleep apnea risk. People, you would be surprised that it's, 20 to 40%, I think, the statistic somewhere in there, that have undiagnosed OSA, and they end up with depression because of the sleep disturbances, etc. So then, I go over risk, benefits, and alternatives, in which we talk about the modes of administration, and because a lot of people are interested in whether or not insurance is going to pay for their psychedelic medicine therapy, and the answer is probably not. And so again, it's really important that you're talking to folks about exactly what's going to happen, even down to the financial responsibilities, because people and their expectations also play a big part into the outcomes of how, you know, they're going to do in their depression, anxiety, et cetera, will improve. So that is definitely part of the discussion, is how will they pay for it? Who will take them home? They can't be driving. So again, the support structure really comes in to play there. And then, of course, the most important thing that people always want to know is, how many do I need to make me feel better? What is the evidence? How long will I be doing ketamine? Do I need to take ketamine for the rest of my life? And the answer is, there's no answer. Everyone is different, and everyone, reacts different. It's usually younger folks that haven't been depressed or anxious for as long, honestly, need less medicine than folks that are in their 60s, 70s, 80s who have been depressed for 30, 40, whatever, many years. So initially I was telling people that the studies out of Yale from Zarate, basically they looked at 6 sessions over 2 weeks, weight-based, 40 minutes, and they saw, I think, 80% improvement. Now, I used to tell people 6 isn't a magic number. That was just, part of the studies, and we'll go step by step. But then there was a more recent study in December of 2021 that was a huge community practice-based study from Osmine, which is the electronic health record I use. I'll talk about them later. But anyways, they were able to look at community practice in real-world data, and they too saw a correlation between 4 and 6 sessions and robust responses and prolonged responses. Now, if you're doing ketamine 3 times a week, you're going to be exhausted. Also, if you have a job and a family, there's no way that it's going to work. And so this also relates to the preparation and letting people know that really it's not, again, it's not a medicine, it's not a magic bullet, it's not like a magic unicorn, whatever, that's going to fix the depression. They really need to spend time in between each medicine session in my office, really unpacking all the lessons they learned, figuring out what the metaphors mean. And that takes time and rest and patience. And so I tell people that they're usually going to be doing 1 session a week is realistic for people with jobs. 1 and 2, really, in almost 2 years, I only had 1 or 2 patients that come twice a week, because it is an intense experience. And the benefits of doing all the, what we call integration or processing in between, are really almost more important than the medicine sessions themselves. So that's it. Oh, yeah, this is my objective way for me to monitor, and the patients to monitor their progress. So I send them surveys that are standardized in the literature before. So we look at depression, anxiety, trauma, adverse childhood experiences, resiliency. We check out their alcohol, the CAGE questionnaire, if they need to cut down, pain, whatever, at a baseline. And then Osmine will send them surveys on a daily basis so that we can look at their mood and see how the mood fluctuates with each ketamine infusion. And you're able to see, honestly, overall, it's usually a positive slope. But again, this is really important to tell folks that healing is not a linear process. There are setbacks, there are loops and turns, and it's a slow going process. And I encourage them through this tech, honestly, really, of this app, that they're able to journal. There's a community on there that they can engage with other people also doing ketamine therapy, and that's it. Let's see what else. Oh, but I didn't actually finish my last slide, in that the total number of sessions usually ends up being 4 to 6, and then, but again, it's really individualized for Now, in terms of exclusions, like I mentioned, super safe medicine, there's only a couple that are hard nose, and it's uncontrolled hypertension, meaning that they have consistent blood pressures, probably over 160 to 90 that have been documented, and they're not on medication. So that's not something that they can't fix. It's easy to go to the primary care doctor and have them prescribe, an antihypertensive, and they are um, followed for a couple weeks, and we document a more normal blood pressure before starting. Active psychosis, it used to be a history of psychosis, but I think the ideas in the community is that history of psychosis isn't so much a contraindication as active psychosis, just in terms of this altered state, and you're not wanting to contribute any additional ammunition to mania as well, would be a current mania issue. We do treat bipolar 2 clients, so they're usually depression, but again, I have a couple clients that have had history of, manic episodes, and it's not a definite contraindication. There is talk of, this increased intracranial pressure. Again, with the low dose of ketamine we're using, it's most people would probably shy away from increased cranial pressure, but also it's not that, I don't know. And then active substance abuse is also kind of a tricky topic. There's cases in the literature that they're talking about treating alcohol addiction with ketamine. It's likely that the provider that's giving ketamine would be a addiction psychiatrist in these circumstances. We don't want folks actively using cocaine or other street drugs, just because you don't want to mix ketamine with other sympathomimetrics and then have, a cardiac or a neurological event. Pregnancy, we just don't know what it does to babies, so we don't give it to pregnant people, although we are giving it to folks with postpartum depression and other postpartum mental health struggles, because it comes out in the breast milk. There's studies. Wolfson's group did a study looking at ketamine metabolites in breast milk, and really it's only a couple hours. And honestly, as an anesthesiologist, we tell women having surgery and general anesthesia that they don't even need to dump after having surgery. So the risk of passing ketamine to babies versus a mother that is unable to function or breastfeed or do any other daily activities is going to benefit more from the ketamine than to the possibility of a very minor issue there. As part of the medical workup, I do have them step on a scale just once, so I have an idea of what the weight is we're going with for the first infusion. I usually do a weight-based calculation. Again, like in the physical exam, I want to look to make sure there's not obvious risk factors for thyroid or sleep apnea. We talk about the informed consent, risk benefits alternatives. During a infusion, I collect their blood pressure, heart rate. I look at their breathing, their oxygen saturation continuously, although that's probably just because I'm an anesthesiologist and I'm biased for more information than less. A lot of my psychiatry colleagues and other folks that are doing more intramuscular and sublingual ketamine administration are more taking baseline and then maybe one during a session and at the end before they leave. That being said, just because you're not monitoring changes doesn't mean they're not happening. And there's always a discussion in the ketamine world whether or not, transient changes in blood pressure and heart rate really have a big impact, or if it's just, we're just treating numbers. So that's definitely a discussion to be had. As far as what I tell people in terms of adverse reactions, it's very minimal. Again, just really you get a slight bump in blood pressure and heart rate. And so for folks that are already hypertensive, again, we want to make sure they're on antihypertensives. All the other kind of adverse effects are more side effects, and they relate honestly to the brain running a marathon. So, you get this dreamlike state, which they call a side effect, but honestly, we're really looking to see these dissociative symptoms or altered perceptions because that's really telling us what's happening at the level of the receptors. So when you're getting nystagmus or moving of the eye and this dreamlike state, we know that the ketamine is in the brain where it needs to be. So those are actually less likely adverse effects, but things that we want to see. You will see again the little bit of heart rate change, blood pressure change. Most people, the biggest problem is nausea, and it's not during the session, it's after. So I just warn people, it feels like a hangover. And if people have motion sickness, I give them a special anti-nausea patch called a scopolamine patch, which they will put on at their house before they come to my office. And that really cuts a lot of the nausea and dizziness that happen as part of the side effects. Again, moving into really like as patients come into the office, I really prepare them for what they're going to experience. And part of that is setting intentions or little goals that can really ground people if they feel like they're getting too far out. And as an overall, I mean, I'm sure you guys have already heard of set and setting. These refer to the internal and external factors that influence the psychedelic experience. So this set or mindset reflects inner climate, and that's the person's mood, the personality, beliefs, perceptions, and so on. And then setting refers to what's going on outside. So people around them, behaviors, music, smells, and even cultural forces that aren't as readily visible. And so again, the preparation and integration or processing really starts before they even take a step into the office. So I tell people that ketamine and psychedelics is really like a tiramisu. 30% is due to the medicine effects at the neurotransmitters level. 30% is really the therapeutic alliance between myself and the client, the patient and their mental health providers. And then really, again, the 40% is due to what the client discovers as they prepare for and process each medicine journey. So, clarifying these intentions or their little goals before journeys with journaling, meditation, and going back to the breath work has multiple purposes, really. It allows patients to focus on positive aspects of treatment and chronic experiences as they come to the foreground of their mind. So here's a look, honestly, at my first office. I was subletting a little room out of a psychiatry office, and this is what the setting looked like. The most important part, I feel, for ketamine therapy, and honestly, all psychedelics, is curating a really comfortable environment that doesn't feel so medical and allows patients to feel safe. And that's not just their physical body, but also their mental capacity needs to feel like it's safe in the container here. I give everyone a eye mask, and I use special music. There's a company out of the UK called WavePaths that has professional DJs, composers, musicians, and they're creating specific ketamine journeys musically for people to listen to during the medicine sessions, which is awesome. And then here you can kind of see what a patient looks like when this is offered with permission. This was actually my first patient and more of a friend than a patient. So this is what everyone looks like when they're getting ketamine therapy. That's their little mindfold eye mask. Has little holes inside so you can actually open your eyes. It'll still be dark. There's my little infusion pump. You can see the headphones, noise canceling. You can also see maybe if you look closely, the little pulse oximeter, and then my blood pressure monitor that I use is actually a finger cuff that takes continuously. So again, so it's not taking people out of the journey by squeezing their arm every couple minutes, because you want to have the least amount of external stimuli. During this 2-hour appointment, 40 minutes is really this deep dive into self. And as I'm holding space there for each person, I serve as a scribe. So if people have any thoughts they want to share, I basically take notes and send them to them afterwards, really, so that they can revisit what comes up during each journey, while they're processing and integrating. And that leads us really to the most important part of any psychedelic medicine healing journey, ketamine therapy in general. It's, the idea that ketamine is a tool or a catalyst is really need to be stressed to every patient that's considering ketamine therapy, and really everyone else. This is, again, it's a treatment. It's not a cure. It's not a magic pill. It's not a magic drug. It does have these rapid antidepressant effects at the level of the receptors. And so everyone needs to use that little boost from the glutamate that we talked about earlier on. And while that is while the neurotransmitters are in the proper milieu, if you will, for creating change, that's when you need to do these integration sessions or transformation of the lessons that you learn in the ketamine session into real life. And it's, again, why I closely follow with mental health providers that each person works with, so that they can know how to support each client. And this is the time when the rewiring is happening. And so, again, it's really important to encourage a healthy diet, exercise, and sleep, because this is where when you're getting the snow globe effect and you're able to make new pathways, getting into these productive pathways rather than non-productive is what, again, will promote the longer lasting effects. So because I really think that this integration or processing piece is the most important part, I don't have patients schedule sessions closer together than 3 or 4 days, so that they are able to take the time to really consider what they've learned, honestly. And then this last little slide, already talked about it, but it's figuring out how, at the level of the receptor in each session, what's happening, how can we tell it's working? At the end of 6 sessions, when patients start to freak out, they're like, it's 6 sessions and I don't feel that much better. Again, it's like, okay, maybe it takes you a little longer. I've had some patients who really, it was the 8th session, honestly, that it was like a switch clicked on. And then they were able to stretch out ketamine sessions. And this is when you get into how to decide when the boosters or the maintenance sessions happen. And again, it's individual. It depends how much integration they've done. It depends how much therapy they've done. It depends how they've changed all these little factors to really determine, how often they need to come back to me. I would say, though, the typical schedule is after they've done their induction or initial series where they feel like they're at a stable state, it ends up once a month for a couple months, and then most people I don't see again. So it all depends. And I think that's the end. So I can answer or ask any questions.
Thank you so much, Dr. Herman.
Oh, my pleasure.
I really appreciate you providing your insight on the therapeutic uses of ketamine and your expertise surrounding that. I know yesterday, student Dr. Ethan Zerpa had gone over some safe uses of ketamine, in like an emergency medicine field. So being able to compare that kind of use to the use that you have seen throughout your practice is really powerful. I also personally very much so liked the discussion about how these drugs are a tool rather than a cure-all,
Yeah,
and it'll vary from person to person, session to session even. It's
exactly.
just another tool in the belt that you as a physician can use to promote these long-lasting benefits that we hope to see.
Totally.
So we do have a few questions for you.
Sure.
One of our questions were, is there a functional difference between the enantiomers of ketamine, or does the literature emphasis on esketamine have to do more with the marketing and patent laws of the pharmaceutical industry?
Exactly. So, yeah, like you kind of, so the RNS ketamine are both in the generic ketamine, and uh, I'm not clear on why they took the S-ketamine first out to create that as its own medicine. But you're right, it is more of like a marketing and drug company production. Although they are looking at R ketamine, and I think the idea is R might have less dissociative effects. But again, if we're not sure honestly if the dissociation is needed in order to see the benefits. Um, yes, you're getting the drug effects at the receptors in the blood and in the brain, but we're not exactly clear how much that like psychedelic or mystical experience really contributes to the healing process. So and those aren't the R ketamine medicines are in the works, but they're not. There's nothing out yet, as far as I know.
All right, great, thank you.
Mhm.
Next up, we have a question. Um, I've been told that the antidepressant effects of esketamine are largest at the first dose, with rapid drop-off at subsequent doses. I know you commented a little bit on this throughout your presentation, but do you often see that in your clinical practice, or?
So I think it probably depends on what you're treating, and I'm assuming you're referring to suicidal ideation, because ERs are right now when patients come in, or they're starting to, when patients come in acutely suicidal, they'll give them a big um, or one intravenous ketamine infusion, and theoretically the suicidal ideation improves. Now, when you're doing it uh, with the intention of continuing and doing therapy in between, I actually don't see a lot of improvement, honestly, after the first one. And it's on that train, I make sure that I have patients commit to at least two, if not more, sessions, because the first session they don't often feel something, and then they're confused and wondering why they're not feeling. So it kind of it depends on the indication what you're treating, and yeah, no. So the answer, the short answer to the question is no. Actually, I see less improvement on the first, and it really again depends on the integration. And one other comment, I usually give folks a really low infusion their first, or low dose for their first infusion, so that they feel safe, they trust me, because again, like the safety factor is huge. And so they're not having these big shot to the moon experiences on their first time, because that can almost be counterproductive if they're scared or worried or whatever, and they're not yet trusting of the medicine and the container. So no.
All right, great answer. I thank you for that.
Yeah.
Next up, we have a question. Do you check for two failed first-line antidepressants prior to initiating this treatment?
It depends what we're treating, but the answer is usually no. A lot of patients don't want the side effects, or they have tried and they don't want. Um, and so I don't follow so closely the tried and failed 2 to 3 antidepressant um, line of treatment, because as this is off label, and if the patient is deemed to be someone who would benefit both by myself and their provider that they have routinely and has known them for however long they know them, then no, I don't, that's not a hard, fast rule for me. But for Spravato, that's the FDA approved medicine. They have to have 2 documented failed antidepressants and or be acutely suicidal. So that's really the only way you can even get the FDA approved Spravato is to have those, yeah. But with the generic ketamine, there's more of a leeway just because of its off-label nature.
All right, great, thank you. Um, and then one of our questions were how much for a session, if not covered by insurance?
Yeah, yeah, no, that's a good question. I mean, it depends on what area of the country you live in, you know, and also honestly, so in Bay Area, there, as far as I know, in my little Menlo Park area, there's 3 IV ketamine providers. The lowest one, and you're getting very minimal stuff that goes with that, support, features, things, whatever, is $600 a session. I charge $750. The other one in Palo Alto is $850 an hour. So it
Wow.
varies. Yeah, it varies. And that's intravenous. Now, when you're getting into the intramuscular and sublingual administration from other folks that are incorporating also multiple hours of psychotherapy, it can be more. I mean, I know that Wolfson's group up in Marin, because they have 2 therapists for 3 hours in addition to the medicine, they're charging $12.50 for 3 hours, something like this. So it is expensive. Now, after each session, most people will give a super bill so that they can put them to the insurance. Insurance, I've seen actually 60% at one point, depending on what the out-of-network coverage is, they do get money back. So
Wow, yeah, that's great.
yeah,
And I mean, the way I also look at this too is, I mean, a dollar figure, I mean, to a degree,
yeah,
obviously, is even if it's a higher dollar figure, it still can pose such benefit through these treatments that it is absolutely worth it.
exactly, exactly, exactly.
So next up we have a question. Do you know if there's any data or anecdotal evidence of patients experiencing mental health benefits after using ketamine for sedation or anesthesia
Oh yeah,
alone?
that's how, this, and I think there was a study from the 80s, honestly, that what was the name? Sarna? I don't know. Anyway, yeah, for sure they did. And that's what started this whole thing is they were noticing people were waking up happily from surgery. Um, and part of it, yeah, well, yeah, anyway. So yeah, so they definitely, yes, the answer is yes.
Oh, that's really interesting. And then to follow up on that, are there ways in which like this side benefit could be like augmented and like promoted throughout use in like the OR or the ER, do you think?
So it's difficult. And that's probably just by nature of the beast you're dealing with. Honestly, like when I started getting into breath work over pandemic, and as an anesthesiologist, I was still in the operating room, and treating patients, and I was super into this breath work, and it was really helping me just deal with pandemic and stress and all these other things. I was trying to incorporate the breath work into um, pre-op workup or whatever, pre-op suggestions for patients to incorporate prior to surgery with then ketamine in the operating in the operating room, music, all the things. And then, but the problem is, again, if you don't have the proper support for the person and explain what's going to happen and all the integrating pieces, just giving them the drug, they're going to feel good for a week and a half. That's kind of when people are using ketamine as, give me the drug to fix my depression, because a lot of ketamine clinics don't incorporate all the preparation and the integration that I do. And so it's literally people are going to them like, fix me, put the IV, give me the ketamine. And when people are using ketamine as an antidepressant drug, then they're seeing a week and a half. And then in a week and a half, they're like, I need more, just because there's none of that processing. So as far as operating room and getting ketamine and seeing effects. You're going to get the ketamine as a drug effect, which is a week and a half to 2 weeks, honestly.
Wow. Yeah, and I guess it goes back to just what we were just talking about, how it's a tool and
Exactly.
there's more to it than just the drug,
That's exactly right.
for sure. So another one of the questions says, it looks like mTOR activation is a large part of the mental health benefits of ketamine.
Yeah.
Does rapamycin extinguish that effect? And are there ways to enhance mTOR activation to enhance ketamine's effect?
Yeah, these are all good questions. I mean, I'm sure uh, folks that are more knowledgeable of the protein cascades, et cetera. And I mean, back when I was a med student, and but anyway, yeah, no. So that the more research applications, yes, and they are, they've looked at other NMDA receptors antagonists, as far as memantine and some of the Alzheimer's disease, and they're just not seeing as much an effect. But people are working on all those pathways and figuring out how they can augment and et cetera.
All right. Well, in addition to that, we have a question. What are your thoughts on ketamine use after stroke or TBI? Like, do you see any benefit with those?
So I think I've had a couple patients with TBI, and it does help with the depression symptoms associated. I mean, it's not giving anyone cognition necessarily back, but it is helping with the mood symptoms that go along with those injuries. Um, so that's yeah, but there is
Well,
probably
that's
better.
great. I mean,
Yeah.
wow, the audience is loving you. Another question is, what are some of the adverse events that you've seen in your ketamine practice, and what do you think providers can do to prevent or handle those when they arise?
So again, like adverse events, knock on wood, there haven't been any yet. The reason why I really started doing all that additional education of myself for psychedelic assisted therapy training in the IPI course and the CIIS, and going to Wolfson's ketamine training center as an anesthesiologist, I am very comfortable with the physical and medication effects, but what you have to be comfortable with is what happens and how to hold space for people when they get into that dissociative space. And depending on how comfortable the provider is kind of what ends up happening as far as the person journeying, because they are much more acutely aware of emotions. And if they sense anything in you they smell fear, then it becomes, it can become more of an issue. But again, this goes back to like the preparation and explaining in detail. I mean, I gift everyone an hour prep session with a psychedelic coach. They're not a therapist, but they're literally a person who is very familiar with the process of having a journey and what it takes to be in that journey mentally and how to prepare. And so the preparation is really and the preparation is going to prevent all of those adverse events. And so really the only, as I mentioned, they're more like side effects, nausea. And as an anesthesiologist, again, I'm really good at treating and preventing nausea. And the scopolamine patch is like a miracle in a way for nausea. But yeah, so it's just for folks in their practices, it's really taking the time to prep the person and then be comfortable with what can come up in each person in the journey in order to prevent any adverse events. But yeah, no, I haven't had it, knock on wood. Again, it doesn't mean that I won't, but I haven't yet had any adverse events in my office.
That makes sense, though. It's a lot about your comfortability with
Correct.
the
Yeah,
patient's issues that are going
it's
on.
exactly right.
Hmm. And then I have just one more question for you.
Sure.
Is there a difference in the duration of efficacy that you've seen between ketamine infusions and the intranasal admission?
So again, this goes back to like what happens in between the medicine sessions. And the problem with the nasal, so Spravato in general, not necessarily a generic nasal that a compounding pharmacy can create a similar type route of administration, but Spravato specifically, I think is what you're asking, is there's only a high and a low dose. So if you can imagine, I actually had a patient who, I don't know, 170 kilos, if you can imagine. And if you're weight-based dosing, the literature is telling you a 0.5 milligram per kilo. And that's for, 170, whatever that is, divided by 2. The highest dose that you can have in Spravato is 84 milligrams. So if 84 milligrams isn't cutting it for the patient, you're kind of stuck and you're not sure whether you're actually getting ketamine effect. And this patient actually did 6 months of Spravato with a psychiatrist with no effect before coming to have IV ketamine. And it's a matter for the actual drug in terms of the intranasal administration, like the mucosa matters. They have to sit in a certain position. They have to actually not swallow the nasal drip for 15 to 20 minutes. And so if these conditions aren't met, they're not actually getting the ketamine effect. Now, if they actually get the ketamine effect and have those dissociative symptoms in the office, then again, it depends on the integration and the processing and all the journaling and the meditation and the breath work and the exercise and the nutrition that happens in between. And if they're getting the drug effect, and they're doing the integration, then the effects should last just as long. It doesn't matter the route of administration.
That makes complete sense.
Yeah.
And then just to follow up on what you were saying a little bit ago, can you just elaborate a little bit on using scopolamine to control nausea during these sessions? And is that as like a prophylactic, or is that only after somebody has
Yeah. So
nausea and vomiting?
scopolamine is an antihistamine essentially that works on it's good for motion sickness. And actually we use it in the operating room for patients with, actually I give it to every woman between the age of 20 and 60 or maybe even 70 that's having surgery, because there are certain risk factors, like female sex being one of those, that can increase perioperative nausea and vomiting. And so I tried using the scopolamine with the ketamine clients because honestly, it's the same deal. And with ketamine, you're getting nystagmus, which is motion. And a lot of people have long rides home. And so I just treat them. It has to be prophylactic. You're right. It has to be on. I mean, sometimes when they forget to put the patch, I'll just give one before we start. I think 30 minutes. Sometimes, I've heard other people say 4 hours, but honestly, just noting from my own personal surgical experience and ketamine experience that 30 minutes is probably fine to get the scopolamine effect.
All right, great. Thank you so much.
Yeah.
Dr. Herman, before we let you go, I would just personally like to comment that I truly admire the shift in your expertise that you took from the cardiothoracic anesthesia in the OR towards psychedelic healing following your own battle with mental health. I think that for a healthcare professional to make major changes in career paths like that is incredibly brave, and it truly shares a positive and powerful message to our audience, many of whom are medical students just starting their careers in medicine.
Yeah. Well, on that note, I would just say every time I followed my gut or the intuition, and that's a big part of psychedelic medicine as well, is really learning to trust that inner voice. I haven't made a wrong decision. But I do recommend, especially as medical students, looking into meditation and breathwork practices, because as a tool to accessing these non-ordinary states of consciousness, and honestly, the studies that have shown meditation alone, just in really calming the nervous system and making you smarter, even though you feel like I don't have time to meditate, even just 10 minutes once or twice a day, honestly makes a huge difference in stress. And you guys are just starting out, long, hard career. So I wouldn't do it again if it was me, but good luck. I'm being honest.
Thank you so much, Dr. Herman. We have a couple more questions, but unfortunately we don't have time for
That's
them.
fine. They can
Would
email
it be
me.
okay if I sent those over to you and then
Yeah,
had you answer them and we can send them back out to our audience?
yeah, sure.
All right, great. Thank you so much.
And anyone can
Um,
email me if here I can put my email in the chat with any
all
questions or whatever. I'm pretty accessible.
right, thank you again, Dr. Herman, for sharing your
Pleasure.
expertise.
Have a great day, you
Um,
guys.
Thank you, you too. So now I'm going to be handing this over to fellow lead organizer of this conference, Jesse Benzell.
Hello, good morning, or should I say good afternoon. It is my honor to introduce Jacob M. Appel, MD, JD, MPH, who is Associate Professor of Psychiatry and Medical Education at the Icahn School of Medicine at Mount Sinai, where he serves as Director of Ethics Education in Psychiatry and the Assistant Director of the Academy for Medicine and the Humanities. He is currently co-chair of the Group for the Advancement of Psychiatry's Committee on Psychiatry and the Law, and a judge for the 2021 National Book Critics Circle Awards. He is the author of 20 volumes of fiction and nonfiction, most recently, Who Says You're Dead? Compendium of Ethical Dilemmas. Wonderful title there on that last work, Doctor. Thank you so much for being with us today, and you have the floor.
Sure. Thank you for having me. I appreciate the introduction. To my mother, I'm still her son who's not the rabbi, so it's all contextual. Which is better because she used to say, he's a psychiatrist and then pause dramatically and say he's almost a real doctor. So I'm making progress. You mentioned my new book, which came out the week before the pandemic started, Who Says You're Dead? It turns out if you write a book about medical ethics a few weeks before a pandemic, nobody buys it. So there are 30,000 copies now in the Algonquin warehouse. That's good for all of you because if anybody emails me, and I have my email on the slides, I can send you all free copies. So just shoot me an email with your postal mailing address and the publisher will send you one directly. All I ask is if you ever sit next to Oprah on a public bus, you just hold it up and pretend you're enjoying it. On that note, I'm going to try to share my screen. Let me see if this works. Can you all see that?
Looks perfect. It's not full screen yet, and now it's full screen. Wonderful.
Fantastic. Make sure it moves, and we are in business. And I'm actually going to begin with a joke on the subject of rabbis. And I tell you it's a joke in advance because if I didn't tell you it was a joke, I am a bioethicist you might not know. I remind you, I am giving you a free book, so you owe me. Laugh a little bit. It's actually a pedagogical joke, though, so it does serve a purpose. So a rabbi goes and plays golf on Yom Kippur. For those of you who are not Jewish, Yom Kippur is the holiest day in the Jewish calendar. You're supposed to go to synagogue and pray. You are certainly not supposed to go out and play golf. And he scores a hole-in-one on every single hole. And the angels are distraught by this. This guy scores a perfect 18, and they go to God and say, God, what are you doing? He's a holy man. He's sinning. You couldn't commit a worse sin, and you're rewarding him. And God looks at them and says, well, he had a good game, but who can he tell? It's cute. Get a smile or two. I mention that because it's actually pedagogically relevant here, because you've heard this amazing lecture from Dr. Herman on all the things that psychedelic medications can do. And I imagine you would more of them yesterday. Now I'm going to tell you what you can't do, the things you can't tell patients, and when you can and when you can't do them. So with that in mind, let me see if I can get my screen to move. I will mention that the first half of this lecture may be rather dull, but it's essential to get to the second half of the lecture, which I think is more interesting. Trying to make you all visible so I can see you and the string at the same time. Since I grew up in the era of two paper cups and a string, that is more challenging, but there we go. So first, I want to talk about the history of the regulation of psychedelic substances, which is not that exciting. Then I want to talk about the history of the standard of care and how we figured out what doctors are allowed to do, which is also not very exciting unless you want to be a malpractice lawyer. But then I want to discuss about the implications of expanded access to psychedelic substances in the context of malpractice law and the standard of care, basically telling you what you can do and what you can't do. But you need the first two legs to get to the third one. So with that in mind, I want to begin by mentioning that historically, the regulation of medicine really was the Wild West. So until the 19th century, physicians were largely unregulated in the United States. You wanted to be a doctor, all you had to do was write doctor on a sign, hang it up, nail it to a wall, you were a doctor. Maybe you want some experience, you found a barber who was pretty good, you did an apprenticeship for a few years, really high powered, you worked with a dentist for a few months, suddenly you were a surgeon. The first licensing of doctors occurred in New York State in 1906, and it was designed primarily to regulate turf, meaning there were these doctors who engaged in what was known as regular medicine, where they had theories and they applied them to patients. And then there were these interlopers called empiricists that used evidence and looked at what actually happened when you treated the patients and tried to apply that to future cases. And the regulars controlled the medical board and were concerned the empiricists, which is presumably what we all do today, were interfering and charging money and taking away their business. So they regulated doctors to keep people using empirical evidence from practicing medicine. They repealed this regulation in the 1840s, and a whole bunch of states went through the same process. So by 1850, there were only 3 states in the country that regulated doctors: Louisiana, Michigan, New Jersey. And this led to the largest number of doctors per capita probably ever in the history of the world. In 1860, there was a doctor for every 571 people in the United States, depending how you define the word doctor. So now I want to begin by talking about the regulation of psychedelics and how we got there. And let me see if I get the screen to move. There we go. So there was a pre-regulation era in the 19th century, and you can see some advertisements from the late 19th, early 20th century for various medications: cocaine tooth drops, heroin hydrochloride, made by Bayer, the same folks who made aspirin. There were lots of panaceas on the market. These were known as patent medicines. Some of you may know about this. The first effort to regulate medicine in the United States actually was not with pharmaceutical substances, so to speak, but with biologics. There was a lot of concern that biologics were being marketed in a dangerous way. There was a brief effort in the 19th century to regulate fake smallpox vaccines, but the major impetus occurs in the early 20th century. And some of you may know the story. There was a horse named Jim, and they used serum from this horse named Jim to make anti-diphtheria toxin, and diphtheria was a disease that killed 20,000 people a year during this period. Unfortunately, the horse named Jim happened to carry tetanus, and they gave it to a large number of children who then died of tetanus, the most famous of which was a 5-year-old girl in St. Louis, which became a national news story. There was a similar episode in Camden, New Jersey, shortly thereafter, and this led to the passage of what became known as the Biologic Control Act of 1902. And it basically allowed the government to regulate biologics. Any other medication you wanted to prescribe in this era, all you had to do was go to a store and buy it. There was no regulation at all of other medications. This changes in the early progressive era. You probably vaguely remember the progressives from high school and Upton Sinclair writing about people finding their fingers with their wedding rings in the meat and all that. The driving force actually on the medical side was a man named Samuel Hopkins Adams, who wrote a best-selling book called The Great Fraud, in which he talked about similar miscarriages of hygiene in the drug industry. And it led Theodore Roosevelt to sign the Pure Food and Drug Act of 1906. At the time, food and drug law was enforced by the Department of Agriculture, and that's Harvey Wiley, the man in charge of enforcing it. He was a professional chemist. There was no obligation to make safe medication under the Food and Drug Act. All you had to do was tell prospective customers what was in your medication. So you could sell them cocaine as long as you told them you had cocaine in your Coca-Cola. And there was actually a fair amount of this. The statute specifically required the quantity or proportion of alcohol, morphine, opium, cocaine, heroin, eucaine, chloroform, cannabis, et cetera, to be noted on the label. The first actual attempt to restrict access to any substances was the Harrison Narcotics Tax Act of 1914. This is right before World War I. The government wants to make money. Secondarily, they're interested in decreasing the use of these substances. And you can see that's Francis Harrison on the left, the representative from New York, who drove the bill. It basically effectively banned the non-prescription sale of opiates and cocaine. So if you wanted to use heroin, you could still use heroin, but you had to go to your doctor and ask him to give you a prescription. The good old days. Things started to change in the Prohibition era. And this is area, for those of you interested in my research, this is one of the areas I studied. You can look at my articles on this. I've done a bunch of work on the prescribing of alcohol during Prohibition. Because as you probably know vaguely from high school, the government in 1920, under the Constitution, banned the Volstead Act, banned the sale of alcohol. But alcohol was used in a whole bunch of different medical purposes. And the question was, how could the government regulate alcohol in this context? Now, I don't think you can answer trivia questions over the setup, but I will give you a trivia question to think about, especially those of you in medical school. In the early 1920s, in the Prohibition era, there were 2 treatments for a myocardial infarction for a heart attack, 2 long-term treatments available in the United States that were prescribed. So obviously, in the short term, maybe they gave you aspirin, they gave you morphine. But then what did they do next? Anybody know, by the way? I don't know if there's a way. So one method was bed rest. And that's probably something you've heard from your parents, your grandparents, spend 6 months in bed. The other pioneering method, which was driven by John Davin, who was a cardiologist trained at Johns Hopkins, was beer. And he prescribed beer for all of his patients, and he had a whole national following, and this caught on. So whose patients did better? And think about this for a second. The patients on beer did much better. Now, why did they do better? They did not do better. And those of you who are first-year medical students, when I teach this in person, always gets the wrong answer that there's some curative effect in beer for cardiovascular disease. Obviously, if there were, the world would be a much better place. The answer is that if you put people in bed without anticoagulation, they all have second events, they have strokes, and this killed tens of thousands of people for the next 40 years. In fact, it only changed when President Eisenhower decided he didn't want to stay in bed and got up and started walking around after his heart attack, and it caught on with the public that maybe this wasn't necessary. I mention that in part because we want to really question the old canards about what we're doing. Half of what we're doing may be wrong, and this is one of the themes through both my lecture and I think through Western medicine. This has occurred over and over again, removing thymuses from people because we thought that they were abnormal, or from children, or in the 1970s, treating perfectly benign arrhythmias that showed up on EKGs as the technology became perfected with antiarrhythmic drugs that caused severe cardiac malfunction. So there's a long history of doing this. If I can remember, I will share with you one other thought, and then I will actually get back to the regular lecture just to prove my points, which is that Franz Alexander is the father of consult psychiatry. And in 1948, he published an article on diseases that he believed were caused solely by psychogenic causes and could only be treated by talk therapy and not through medical intervention. And his list of the Holy Seven eventually expanded to the Holy Eight, and included, if I recall, rheumatoid arthritis, eczema, psoriasis, ulcerative colitis, Crohn's, asthma, MS, essential hypertension, peptic ulcers, and I'm getting old. I can't remember the last one, but you get the picture. So we want to question what we do. Give you a couple of examples of prescriptions. That is Woodrow Wilson's prescription. Winston Churchill's prescription when he came to visit the United States and wanted to carry brandy with him. The government, in the same way that it regulated alcohol first with taxation, then regulated marijuana with taxation in 1937. I'm sure you're all familiar with Reefer Madness. It changed its mind about alcohol shortly before it started to regulate marijuana. During this period, everything else was largely fair game. You wanted to go to your store and buy the limited number of other medications on the market. As long as they were fairly open to what was included in them, there was minimal regulation. This began to change in the 1930s. And the first effort to really regulate medications was the Federal Food, Drug, and Cosmetics Act of 1938. It came about because the Massengill Company, which I believe is still in business, prepared a medication called elixir of sulfonamide that consisted of a sulfide drug and then diethylglycol, which, as you may know, causes kidney failure, and raspberry flavoring. And there was no dialysis in this era. 100 people died. They had done no pre-testing on either human beings or animals. It led to a large response. The driving force was this man, Royal Copeland, who was actually a homeopathic physician. He was opposed to all medication except in microdoses. So, of course, he wanted to find a way to regulate it. And it led to the creation of the Food and Drug Administration. There are then a few modifications in the 1960s. For those of you who are interested in going to law school or who the math doesn't work out for, you learn about the Kefauver-Harris Act, but it's largely unchanged until 1968. And 1968 is the big event. You may remember that there's a lot of turbulence in the country in the late 1960s. There's Woodstock. 1970, there's Kent State. There are people concerned about figures like Timothy Leary and people tuning in and dropping out. And among the people who are concerned are Harley Staggers, who's a former sheriff who becomes a congressman from West Virginia, and Thomas Dodd, the father of the presidential candidate, Chris Dodd, who's a senator from Connecticut. And they expand the Federal Food, Drug, and Cosmetics Act to create meaningful penalties for a number of hallucinogenic substances, most notably LSD. The important thing is that nobody enforced this law. Even though the federal government created this law in 1968, nothing happened. And then what happened? Woodstock happened. And President Nixon became aware at a much larger level of the public perception of these problems. And that led to the act you're all familiar with, the Controlled Substances Act, which is 1970. And Title II of the Controlled Substances Act schedules a bunch of drugs. Now, for those of you who are not yet physicians, I want to mention that the terminology is important. We often refer to pharmaceuticals as controlled substances. Controlled substances are all substances regulated under federal law. Scheduled substances are those listed in categories 1 through 5 under the Controlled Substances Act. And to prescribe a controlled substance, you just need a medical license. To prescribe a scheduled substance, you need to have a DEA number. There are much more strict limits on who can prescribe them, and there are significant criminal penalties for violating these rules. I'm going to use as a model today psilocybin because it is a Schedule I drug. I want to talk a bit about Schedule I drugs. So the rules for scheduling a drug on Schedule I, which are by far the most restrictive, are the substance has a high potential for abuse. There are no medical uses for the drug that are established in the United States, and there is no other substance accepted for treatment in the same condition or that can substitute for the drug. So you may not agree with this. I don't agree with this, but the government views the following substances as fitting under this category: heroin, marijuana, psilocybin, mescaline, LSD. There are, I think, about 50 others. There's contrast with Schedule II substances for which there is a potential medical use, like methamphetamine, seconal, cocaine. They expand the list every year. It is much, much harder to get off the list than it is to get on the list, for what it's worth. It is very rare that anything comes off the list. It also is very difficult to do research on Schedule I substances. And that is why it was actually fairly significant when in 2012, the Congress passed the FDA Safety and Innovation Act that allowed the FDA to grant breakthrough status to a number of drugs, including those classified as Schedule I, to expand access for research. And basically, if there was some increased triggered potential that there might be a medical use, it became easier to do research. And it's worth noting that in 2017, in a major step, and probably, I believe, the first one for a scheduled substance, the FDA granted breakthrough status for treating PTSD to MDMA. And then in 2018, more relevant here, the FDA granted psilocybin breakthrough status for research, which continues to this day, and I believe it's renewed every year. That allows stage 3 trials to show safety and efficacy. Why does this matter? If you can show that it's safe and it's efficacious, then it no longer qualifies as a Schedule I drug. And then obviously the government will move it to a Schedule III or Schedule IV. Now you keep believing that because marijuana has, in multiple settings under government sanctioned research, been shown to be both safe and efficacious in certain contexts. And despite multiple efforts, the FDA has pointedly chosen not to reclassify it as a Schedule III or Schedule IV substance. There's no reason to believe they will do the same with psilocybin. But food for thought. In theory, it could happen. That being said, there have been decriminalization efforts at the local level. This gives you a sense both of the geography of these. They do not suggest a landslide of popular opinion. As Denver goes, so goes Seattle is not a rallying cry in American politics. But you get a sense for blue states are those where local municipalities have legalized psilocybin. And in Oregon, which I'll talk about in a second, has actually decriminalized it on the state level that many of you are probably aware of. And that is Measure 109, 109. Measure 109 allows for the personal use and manufacture for personal development, including medicinal use of psilocybin at the state level. It's important to remember it remains illegal federally. So if you want to run your psilocybin business, this raises a whole bunch of problems. For example, you can't use the banking system, you can't buy with a credit card, you got to walk around with large quantities of cash. Then the government says that since you're involved in a federal crime and walking around with large quantities of cash, under the Repossession Act, they can confiscate your cash and you're back at square one. So it's a really bad business model, but in theory, it is legal. At the state level, the government can still come along and arrest you because it still is a federal crime, and actually a fairly serious federal crime, particularly manufacture and transport. So the question then arises as how do federal regulations against substances regulated by the Controlled Substances Act mesh with state regulations or state laws that say something is legal? And the Supreme Court has actually addressed this question in the case of what was originally Rice versus Ashcroft, and then when John Ashcroft was replaced with Attorney General Gonzalez, became Rice versus Gonzalez, and an appeal Gonzalez versus Rice. And that is Angel Rice, by the way. She is a woman in the state of California who used medicinal marijuana, where the substance is legal, and she sued the federal government saying that medicinal marijuana used for personal use clearly did not fall under the powers of the federal government to regulate. And I'm not sure if it's discussed on the slide, but if it's not, the problem with this case, maybe it's on the next slide. Yes, it was a highly unusual case because it got the business of drug regulation or pharmaceutical regulation mixed up in a larger debate at the national level. And this is where it gets really dull, and I'm going to make it really, really simple. The federal government is allowed to regulate commerce between the states, but it's not allowed to govern commerce within the states or other private matters within the states. And medicine is usually fallen as an in-state matter. But over the years, the government has expanded its definition of interstate commerce to include a very large number of things. At the most extreme, in the 1940s case of Wickard versus Filburn, the Supreme Court ruled that a man growing wheat on his own farm was engaged in interstate commerce, even though he was only feeding the wheat to his farm animals. Because by feeding the wheat to his farm animals, he infinitesimally impacted the international price of wheat by not selling the wheat on the open market. Now, you may all think that's absurd, but that's how courts work. Now, that actually matters because there's this heated debate in the Supreme Court over the extent of interstate commerce. And at that time, at least, the people who wanted a broad definition were in the majority. And therefore, even though they may have philosophically agreed with legalizing marijuana, and Justice Stevens, who wrote the opinion, in other areas we know strongly favored, he was a very liberal justice, strongly favored the rights of marijuana users and owners, he felt it was more important to establish the federal government's control, and therefore he upheld the law. This matters today because even when states legalize psilocybin for personal use, the federal government can still regulate it because it's still trapped up in this battle over subjects that have nothing to do with it. However, the good news, if you think Stevens's politics are more important than his legal views, is that in 2009, Barack Obama decided they were not going to enforce this federal law. First, they deprioritized it, but eventually decided they were not going to enforce it in states where medicinal marijuana was legal. This is actually more complicated than you might think because you have a legal prescription in one state, you move to a different state, the police arrest you, they decide to confiscate your car, you have very little authority to appeal that. It is likely that the federal government at some point, as more states legalize various hallucinogenics, will adopt the same policy. As of now, that is not the case. So in theory, the federal government will enforce, for example, psilocybin regulation in Oregon. There's a unique carve out for marijuana as we speak. So that was my first half of the lecture, which I promised you was going to be very dull. Now I want to talk about the standard of care, which I will talk about a bit more quickly, and then we will merge the two. So I want to begin by saying that we need to figure out what the standard of care is for a product that is legal under state law and not legal under federal law. So in order to answer that, you need to figure out what we mean by the standard of care. So many of you are going into medicine. You probably are very interested in malpractice law. You probably have vaguely heard that malpractice has 3 elements to it. You need to have a duty to a patient, you need to breach that duty, and you need to have damages resulting from that breach. The standard of care entirely deals with what it means to breach the duty. It concerns what it means to give such a low quality of care that the patient isn't getting enough that they then have a right to sue to say it was deficient. The standard is usually a descriptive standard. It's an example of what other doctors actually do in the community. So in a very famous case, Helene versus Qari, There was a woman who went to her ophthalmologist in Washington State, and she said she couldn't see very well. And her ophthalmologist gave her a pair of glasses, and she came back a year later and gave her a better prescription. This went on for about 12 years, at which point the patient went to a different ophthalmologist and was told she had glaucoma. And her first ophthalmologist had misdiagnosed her, and she sued. And the first ophthalmologist said, everybody else in our area, all the other ophthalmologists, use the same procedure. We don't test for glaucoma in younger people because it's not cost effective. Even though the test only cost 5 cents, it was readily addressed in the literature, it was widely used nationally. And the court said, if other doctors fall so far behind what a reasonable person would expect, you can still be held liable for malpractice. So now it is usually a descriptive standard, but there are narrow areas where it's a prescriptive standard. The second thing you want to know is that it used to be a local standard, but now it's a national standard. Why does this matter? Because if psilocybin is illegal in one state, are you held to the standards of providers in that state, or are you held to the standards of providers more broadly? And the third element of the standard of care you need to think about is the standard of care is generally determined by experts, but not always. And I will give you an example of why. Jerry Canterbury, I was actually involved in his case, after the fact, was an FBI clerk in the 1950s. And he went to the leading neurosurgeon at the time, Dr. Spence, to get routine laminectomy. And after the surgery, they forgot to put the bed rails up in the post-op, and he fell out of the bed while he was under anesthesia or slowly. Yeah, it's a terrible case. And he ended up paralyzed, impotent, incontinent, and he sued. And he could not find anyone, no doctor, no nurse, no hospital administrator, in the entire Washington, D.C. area to testify, no matter how much he paid them, that bed rails were part of normal practice in the post-op after surgery. Why? Because doctors didn't testify against other doctors. Sort of like in the Rodney King trials, police didn't testify against other police. And without an expert, he couldn't win. Fortunately for him, he got the most liberal panel in the history of the American federal appellate courts. And that's just Spotswood Robinson, the former civil rights litigator from the NAACP, who was the presiding judge, who basically carved out an exception that says that if the average person on a jury doesn't need an expert to figure out that something went terribly wrong, they can make an exception to the rule. And Canterbury eventually won his case. My only contribution to the history of the United States was I befriended Jerry Canterbury later on in life. And when he passed away, I called the New York Times and convinced him to write one of his large obituaries for him, in which I was quoted. That is my entire legacy in the history of the world. I urge you to befriend obscure historical people. You too can get your name in the New York Times. And finally, the fourth thing you need to know about the standard of care is that it's subjective. It's not subjective. It doesn't matter whether the patient actually understood. It matters whether the doctor told the patient what a reasonable person would expect the patient to be told. Why? Because on Monday morning, it is always possible, and I unfortunately have to say there's a certain gendered element to this, to say what the quarterback should have done on Sunday afternoon. So I have lots of relatives who do this. Monday morning quarterbacking. Hindsight is always 20/20. And this really applies to patients, because if you have a negative outcome, you will say, if I really understood the risk with a capital R, of course I wouldn't have undergone the procedure. Obviously, that not being true. That is why, for example, a number of plastic surgeons have begun to videotape their informed consents. I would actually suggest that if you are prescribing something like psilocybin, or for that matter, ketamine, something that is somewhat off the beaten path, which there is still some controversy, I would videotape my consents as well. Perfectly legal, there's no downside. That way, when you go to court, it's very clear exactly what you told the patient. One question you need to ask is, do I need to inform the patient that other people can do it better? So example, let's say that I have a 60% chance of repairing brain aneurysms, but the hospital across the street has an 80% prospective success rate. Do I need to tell them? And the answer is generally no. Why? The concern is you would create bottlenecks, that everybody would go to the better hospital, that nobody would go to the worst hospital, that the quality of care there would get lower, and that over time, those less efficacious hospitals would serve underserved populations. And I always say informed consent is only useful if you have the means to use it. if you go across the street from my apartment to the Carver houses, which are low-income public houses, and you tell them that the success rate for aneurysm repair at my hospital is 60%, but it's 80% at the Mayo Clinic, that's like telling them it's 80% on the moon. It doesn't do them any good. It just makes them feel bad because they can't get there. There's an exception to this rule, though, that relates to psychedelic substances, or it's a significant impact. And there's a case of Ashraf versus Chestnut Lodge. Ray Ashraf, he actually was a doctor. He was a nephrologist in Maryland. And he developed severe depression in the 1970s. And he checked himself into the local upscale hospital, which was Chestnut Lodge, which was one of these fancy retreats like McLean or Menninger, where you pay thousands and thousands of dollars. And they treated your depression. Only they only treated his depression with talk therapy. And he got 8 months of psychodynamic psychotherapy for his depression, even though there were a whole bunch of medications on the market, like tricyclic depression, the antidepressants. And he didn't get any better at all. And then his brother-in-law checked him out and took him to the local public hospital a few miles away, and they put him on a tricyclic. And 6 weeks later, he was much better. And 2 months later, he was back to practicing nephrology. And he sued, and he settled with Chestnut Lodge. We don't know the amount he settled for, but a year and a half later, Chestnut Lodge was turned into condominiums. He basically bankrupted the hospital. We actually know that he largely was the force in bankrupting the hospital. Why does this matter to you all? Because while you don't have to tell people that other people do it better, you do need to tell people if there is an alternative treatment that is reasonably efficacious that they might be interested in. And the question arises whether, if you're in a state like Oregon, where certain substances like psilocybin are legal, or for that matter, you are treating depression, treatment-resistant depression, and ketamine is available, you need to tell your patients that this is available. And we'll get back to that in a moment or two. I want to mention that you can't contract out of the standard of care. So the extreme example I always use is, let us say that at the Great Mount Sinai Hospital, we normally do surgery in an OR with a senior surgeon and a scalpel, but we offer you a discount. We will do it in the lobby with a junior resident and a cleaver. Now, even if you fully understand the risks of that, we videotape it, there's no doubt, you embrace it, you want to save money, you're cheap. If something goes wrong and you sue, you're still going to win, because it is a widely accepted standard in the United States that you can't contract out below the standard of care as a patient. Now, nobody's really going to have surgery done with a scalpel, but with a cleaver. But the question arises whether complementary, alternative, unapproved, unproven medications fall under that exception where you're contracting outside the standard of care as a patient. And the answer is yes. So in general, if you're doing something that other doctors aren't doing, you run the risk of liability, no matter how informed the patient is, no matter how much they agree to it. There is an exception to this. And the question that we need to ask ourselves today is whether or not drugs like psilocybin and other hallucinogenics that become on the market are going to meet this requirement. And it is known as the respected minority doctrine, or to some people, the 2 schools of thought doctrine. And it basically says, even if a majority of people do things one way, if there's a meaningful cohort of doctors who do it a different way, and this could be a combination of some evidence in the literature, some widespread practice, if these are particularly prominent people who are doing it, there's no hard and fast rule, but rather sort of a gestalt of all of it brought together, then even though you're not practicing by the standard of care, you're also not liable for malpractice. If you don't meet that threshold, if you don't meet the respected minority threshold, then you're in essence doing research, and you should be doing research with IRB approval because you're engaged in human subjects, and that will protect you as well. If the IRB approves it and you have meaningful informed consent, you're not going to be liable to malpractice claims. But if you're not a respected minority and you don't have research approval, that is the window where you're going to get yourself in deep trouble. And a number of states actually have seen significant payouts for patients who met neither of those criteria, who fit into that gap. I do want to mention the concept of right to try laws. Most states now have right to try laws. I think the conference is still being physically held in New Jersey. And New Jersey, at last check, does not, nor does New York, where I am based. I imagine many of you are familiar with the concept, at least, of right to try laws. They basically say that if one is a life-threatening condition and you've exhausted all approved treatment options, you can't participate in any clinical trials that are available, and your doctor endorses it and you give informed consent, you can still get medications that have not been approved by the FDA. The bottleneck, by the way, that people often don't understand is the manufacturer still has to be willing to let you use these medications. For hallucinogens, for psychedelics, that's usually not an issue, because they're usually available for someone, whether it's someone on a street corner or someone designing them privately. It doesn't take the same level of scale as many other complex pharmaceuticals do. This has now been adopted by federal law as of 2018. You can look at the language of the law on the left, it's very similar. The question is whether or not the Federal Right to Try Act overrides Controlled Substances Act as it relates to these substances. Meaning, if it's not a scheduled substance, if it's anything else out there, you have a right to try. But if it's something that's already scheduled, but you have some experimental use for it, or you think it now may work, does it override the original provision? And a number of doctors have claimed that it does, and some actually are taking a significant risk by prescribing based on that theory. So far, the federal courts have said that it does not. And the DEA has very strongly taken the position that it does not. And remember, we are in this complex situation where both the DEA and the FDA govern substances under the Controlled Substances Act. So you really need sign off from both of them in order to prescribe something. And right now, the FDA has given very mixed language, but the DEA has given very clear language. They do not think there is a right to try for scheduled substances. Sunil Agarwal strongly disagrees. He is a physician, I believe, in Washington State, and he actually wrote a letter to the DEA asking them to clarify their policy to find out whether or not he had a right to prescribe psilocybin to dying patients. And he tried to find, all credit to him, a case that seemed paradigmatic of where you might want to allow an exception. And he actually got the attorney generals of a number of states. And I will add, they were both states represented by Democrats and by Republicans. There's much less partisan divide on the issue of hallucinogenic substances and psychedelics than in most other areas, both in policy and in medicine. It's often surprising to me. It brings out both a liberal tradition of trying and a libertarian tradition of resenting government intrusion. So he had a very strong coalition backing him up. And he sued. And the Ninth Circuit, which is the judges governing California, refused to rule on his case. They basically said he didn't have standing. Why? Because an advisory letter from the DEA telling him he couldn't do this wasn't the same thing as government action on the subject. Now that creates a fascinating paradox, and you see what the problem is, because neither the DEA nor the FDA is willing to make a clear decision on this until someone gets arrested and someone faces the consequences of it. But nobody's willing to get arrested and face a very long prison sentence and losing their medical license and the like to find out what the law is like. And we actually, this was earlier this year, in 2021, late 2021. We are now in this bind where there is no test case because the government has created this complex window to avoid a test case. I actually have no idea how we're going to get around this. It is rather a puzzle. So now I will offer you 3 sample cases, and then I will pause, just things to think about. And you can think about how you would apply the rules in each one of these. So first case, Dr. Magic is a geriatric psychiatrist in Oregon, where psilocybin has been decriminalized under Measure 109. The patient presents to his office seeking treatment for depression in the setting of pancreatic cancer that is not resolved with antidepressants or talk therapy. Patients are poor candidates for ECT and other therapies due to underlying medical comorbidities. Magic recommends psilocybin, and the patient purchases the recommended quantity. However, the patient, who is naive to the drug, suffers an unexpected negative reaction in which he becomes paranoid and in panic runs down a staircase and breaks several bones. I want to emphasize this is a very unlikely occurrence, but like all other malpractice occurrences, if you treat thousands of patients, there will always be negative outcomes. So the patient sues for malpractice. So assuming Dr. Magic engaged in disclosure accurately of the risks of the intervention, and we even say he actually said to him, look, you could become psychotic, paranoid, run down a staircase, break your leg. Complete disclosure. Can the lawsuit succeed? And the answer is maybe. What are the issues? First, you need to ask, does psilocybin qualify as a treatment under the respected minority doctrine of physicians, or is the doctor contracted outside the standard of care? And secondly, once you answer that, you need to ask, can an intervention that is illegal under federal law and in 49 states, which is presumably a national standard, still qualify as either the standard of care or under the respected minority doctrine in the one state that allows it once we embrace a national standard? And the third thing you want to think about that I don't think we've talked about yet today is, will Dr. Magic's medical practice insurance cover this? Because in reality, no matter how broad the law is, no matter how concrete it is, nobody's going to be willing to engage in these kind of interventions unless they're able to get insurance coverage. And that's going to be particularly difficult going forward, particularly if there's a state patchwork of regulation. So a second case to compare this to is Dr. Magic's a geriatric psychiatrist in Oregon, where psilocybin has been decriminalized under 109. Patient presents to his office seeking treatment for depression in the setting of pancreatic cancer that is involved. And as I said, the patient is not a candidate for ECT. Dr. Magic does not recommend psilocybin, doesn't mention it at all, and the patient continues to suffer from depression for another 6 months. In frustration, he seeks care elsewhere, and another Oregon prescriber recommends psilocybin, and his depression resolves within a week. Now he sues the first provider for the opportunity cost of all of this time that he's lost, sort of like Ashraf versus Chestnut Lodge. So can the patient win the lawsuit for failure to give adequate notice? And the answer is again, maybe. The issue is, does the evidence for psilocybin use in depression rise to the level where it is now an acceptable reserve treatment like ECT, that the provider has an obligation to make patients aware of its existence, even if the provider does not personally offer it? And this is a moving target, of course, as things become more widely acceptable, as other states will legalize this, as the literature expands, as I imagine the research that your other lecturers have talked about becomes more expansive, the obligation presumably increases, and at some point you will hit a tipping point where this does reach reserve status. And then the third and final case to think about is a geriatric psychiatrist in Oregon, where psilocybin has been decriminalized, is presented with a patient seeking treatment for depression that hasn't resolved, not a candidate for ECT. Magic recommends psilocybin and the patient's depression resolves. However, the patient is the subject of mandatory drug testing at work, and when his urine comes back positive for psilocybin, he is fired. The patient sues his employer and files for unemployment insurance. He also sues Dr. Magic for failing to disclose this risk. And this raises the question that comes up both in a number, I serve in the IRB and do a lot of illicit substances cases like these. The question, how much legal information do you have to provide either patients or research subjects about the legal risks they may entail from using therapeutic substances or potentially therapeutic substances? And the answer here may actually surprise you. So there is a case on the subject. It's Employment Division versus Smith from 1990, in which a Native American, I believe it was in California, was using I believe peyote, a hallucinogenic substance, as part of a religious ritual, which protected under the First Amendment, this particular use. And unfortunately, this individual was also collecting unemployment, and they were tested for substances under unemployment, and they lost their benefits as a result. And the question was, can you have a right to use a medicinal substance that the state can still criminalize for employment purposes? And the answer is yes, which means that unless the law changes, which it is not likely to anytime soon, this individual can be fired for having psilocybin in their system and is likely not going to get unemployment in most states. However, they still have a strong malpractice case against Dr. Match, against their provider, for not disclosing to them all of the legal risks that might entail in use. And I think this is going to be the particular area, the merger of medicine and law, that becomes very challenging for physicians, because they're going to have to, if they're engaged in this field, going to be fairly aware of exactly what the legal implications are for the use of various substances. And I don't think it's going to be acceptable just to say something very broad like you could face legal consequences as a result of using this drug, because I don't think most patients will internalize that in a meaningful enough way or understand its meaning significantly enough to actually change their practice. Because most people will think, well, maybe there are legal consequences, but my doctor is still giving it to me and I trust my doctor. And I think that is where we're going to see litigation going forward. So that was about 43 minutes. I will stop there and I will stop sharing my screen, but if people want my email for a free book, they can take it down. It's my full name, Jacob M Appel at Gmail, and I will answer any questions people may have.
Dr. Appel, that was fantastic. I can't tell you how many times I've approached faculty and attendings and almost everybody I talk to about this subject, and you've been able to kind of clarify an incredibly complex situation. So we do have some questions from the chat. The first question I'll read out to you is, what are the ethical boundaries for future applications of psychedelic medicine in child and adolescent psychiatry? I'll expand that to in patients with mental disabilities or other vulnerabilities. these?
Sure. So, there's a lot of debate over these sorts of issues, but my general view is that we don't make a distinction in terms. Once we establish something as safe and efficacious, we don't make a distinction between the pediatric, the adult setting, or the compromised setting, because we'll use the same standard for consent that we use for other areas where patients don't have capacity, their proxy or surrogate will make decisions, and if not, a best interest standard will arise. I think the more challenging questions that are going to come up are when these treatments may prove efficacious, but parents have beliefs that they don't want to use them. And are there some kinds of interventions that may meet the best interest standard, but are so stigmatized that we don't feel comfortable enforcing them on patients? By analogy, for example, a number of states have laws related to ECT and children or adolescents and won't enforce ECT on adolescents, even if it's the only reserved therapy available, if the parents aren't willing to do it, because something about forcing your kid to get ACT against your will is problematic. And I imagine the same is true here. In the same way, there's a heated debate when they do research on this, particularly in the pediatric setting. They do research, for example, on medicinal marijuana, where it comes up a lot, whether or not you should need two parent consent or even only one parent consent, even if the risk is perceived to be minimal. And I can tell you, on the IRBs I've been on, the general consensus is you require two parent consent because the social stigma, the impact for parents in terms of their perception is such that they won't buy in. The optics will be problematic if you force people's kids to use the substance against their will. So I think it's the optics that are really going to be an issue. Good question.
Very interesting. So you mentioned something about a test case that might be useful towards establishing a national standard. Could you just elaborate on that concept and what the obstacles are in that?
Sure. So the challenge is that in order to see whether or not the Right to Try Act creates an exception to the Controlled Substances Act, meaning the rule that says you have a right to try medication if there's no other intervention, which is a federal law, overrules the previous law as it relates to scheduled substances, or whether it's simply independent of that and doesn't trump it. Pardoning the pun. It's a legal question, but the rules under federal law are in order to litigate whether or not something something is illegal, you have to have standing. You have to have a stake in the case. In order to have a stake in the case, the agency involved has to have made a clear ruling so you can then appeal it. But the DEA refuses to make a clear ruling on whether or not using psilocybin is legal now that the Try Act has been passed. They're only willing to do it when someone is arrested for violating the rule. And nobody's willing to go forward and violate the rule. And therefore, we're in this impasse here. And although I give Dr. Agarwal credit for challenging this rule, I don't blame him. If I were him, I would not go out and get arrested and face losing my career to test the rule. Maybe somebody out there is braver than he or I.
So that's really the bottleneck, is someone brave enough to get arrested for doing it and then theoretically escalate all the way through the chain of courts.
With the caveat that somebody being brave enough, and the odds are very likely with this court, they're going to lose. So if you had a 95% chance of success, maybe you'd be brave enough to do it. If you have a 20% chance of success, it's a much harder sell for someone.
Oh, interesting. Interesting.
Let me put it this way: if I were a lawyer advising a client, I would tell them not to challenge this right now because I think the odds are very much against them.
So what do you think will have to change before the chances of that kind of trial going the other way?
I don't think it's going to come to that. I think what is going to happen at some point is the federal government, you're going to get, whether it's this administration or one that is even more sympathetic to psychedelic substances, is simply going to say they're not going to enforce the rule, and then nobody's not going to have any standing. Nobody can have any standing, but it won't matter. I mean, I would be very surprised if the government decides to enforce its federal ban on psilocybin in Oregon and not its marijuana ban. It's a very hard needle to thread, and that may be challengeable in court independently.
Okay, fascinating. Okay, another question here. What are some of the parallels between the era of prescription alcohol and modern psychedelic or cannabis prescription?
So I will share the negative one first, because I actually do think it's concerning. While alcohol clearly has some medicinal purposes and actually did benefit some people meaningfully, there were also a large number of people who used this as an opportunity to tout many benefits for alcohol, like its treatment in curing smallpox, which clearly are not true. And I think it's very important in the same way that we don't allow medicinal interest in these substances to allow other people to tout them as a panacea that cures a whole bunch of other things. So that's the most striking example that comes to mind. I also think the second lesson is one of the reasons that physicians were able to carve out such a strong niche for prescribing during Prohibition is they were extremely well organized and very well unified on the subject. It became one of their leading political causes. I imagine if physicians' organizations were able to organize and cohere in the same way around hallucinogenic substances and psychedelics, there would be far more likelihood of carving out exceptions from medicinal use.
Mm. Well, that's part of what we're working on right now. Okay, great answer. I've got another question here. And this might be a difficult question because, it kind of asks you to play Monday morning quarterback a little bit, but what do you think is a modern best practice or standard of care that is as dangerous as post myocardial infarction prescriptions for persistent bed rest? If that makes sense.
That is a very interesting question. And obviously, I am far from the expert. I do think that there's a lot of work, and I'm not endorsing the book because there are problems with the book as well, but some of the evidence in Bob Whitaker's book, Anatomy of an Epidemic, about the long-term use of antipsychotics, particularly the Martin Harrow studies, are concerning. I mean, maybe offering people on long-term antipsychotics that give them a concrete benefit in the short run at the expense of significant cognitive reserve in the long run. And I think we've largely ignored the cognitive impacts of long-term antipsychotic use. That's just one example.
Yeah, fascinating. Okay, do we have time for a few more, team? Okay, wonderful. Okay, here's a question. Does the group of doctors for the minority doctrine, sorry, let me rephrase that. Do you think that we have a respected minority in the United States for supporting psychedelic medicine use at this time?
My guess would be and it's not similar to what I think a court would rule. I don't think a court would accept that yet. I think you'll need, because it's still federally illegal, which even though it is not the decisive factor what the federal law is in terms of the respective minority doctrine, it's certainly going to influence a court or a jury. I think you're going to need to have a number of states take similar action to Oregon before you reach that point. I think having something in the literature helps, but when you're only one state as an outlier, it's much harder with a national standard.
Mm-hmm. So we have a few other questions that were submitted, but I feel like you've already addressed a lot of them. I'm seeing if there's anything else here.
Well, I realize I'm the only thing between all of you and happy hours, so.
Yeah, so we do have a lunch break after this. Dr. Appel, I cannot thank you enough. This was such a challenging subject to wrap our heads around, and just to kind of play off of the joke you had at the beginning of your lecture. I was lucky to have very progressive Jewish parents. They said I could do anything I wanted with my life. I could be a doctor or a lawyer. So I can totally relate to your story at the beginning there. All right, well, I guess we'll let you go. Thank you so much for everything. Look forward to those requests for free copies of the book. And thank you so much
for having me.
This was
Stay
fantastic.
safe, everybody. Be well. It was my pleasure.
Okay. Thank you. So for everyone on board, we're going to take a nice lunch break, and we will be returning at 1 p.m. for Dr. Joe Tafur's talk on ayahuasca. Sorry, that's going to be at 2 p.m. Daylight savings. And it's going to be fantastic. You don't want to miss it. Dr. Tafur is one of the few practicing allopathic physicians who's completed a rigorous ayahuasca apprenticeship. So really beautiful insight from this fantastic physician and healer. I look forward to seeing you all then at 2 p.m. Thank you. See you soon. Hey, good morning, Dr. Tafur.
Good morning. Good morning. I'm just at my friend's house here in Colombia. I don't know if it's the best background, but that's where I am.
Wonderful, though. How's the weather?
It's beautiful. Yeah, no, it's pretty nice. Where are you all? You wanna get a glimpse of
Yeah, show us the
what's going
jungle.
on in Colombia? Despite the bad press.
Uh, wow, that's beautiful. That's
Like
fantastic. I'm
like
so
Hawaii,
jealous.
I guess, is what you think of it as.
We're here in gray New Jersey.
Oh yeah, that's good though. Thank you for that.
Yeah, doing our best.
Yeah, that's good. I'm going back to the States soon.
Okay. How are you splitting your time between the States and
Just
the
it's
jungle
not
these
clear.
days?
Yeah, more time in the States. No, but I decided to come down because of the pandemic. I hadn't been down to Peru, in 2 years. So I went to go see my teacher and back to the center.
Wonderful. Yeah, so around 2 o'clock, we'll just probably 2:02. We'll give a few extra minutes for people to come in. And we're
Okay.
also recording everything. So we're hoping to put up videos of these talks up on YouTube later.
Okay.
I'm not sure if we've decided. It's probably YouTube. So yeah.
And who's this? Who else is here with us? There's all kinds of people. Or no,
Yeah, so
just the two of you?
this is the rest of the kind of planning committee, if you will. We never really gave ourselves a formal title, but I don't know, about 9 months ago, I said, I think we should have a psychedelic medicine conference. And then nothing happened for like 3 months.
Yeah.
And then Magdalene really stepped up and started making things happen. And the whole team's just been incredible. They bring all of those organizational, detail-oriented skills that I sometimes are not my strength. So I like to think I have aspirational skills, but maybe not so much organizational skills.
Right.
But yes, it all came together, and it's been fantastic. Yesterday we had Dr. Strassman speak. He gave almost a 2-hour lecture on mostly based off of his new book called The Psychedelic Handbook. And
Rick Strassman? Rick Strassman or Rick Doblin? Rick
Dr. Rick
Strassman?
Strassman,
He has a psychedelic handbook now.
it's I think it's actually just releasing in a week or two, so you can
Okay.
pre-order it.
Cool.
And then this morning we had Dr. John Appel or Appel, Jacob Appel,
Mm.
speaking on the very fascinating legal socio developments around psychedelic medicines and um, really where things stand right now in the country and how it's so difficult to get a case up through the higher systems of court and how things might play out in the next few years. So it's been really fascinating. Yeah.
That's great. Yeah, that's what else? I mean, today was just that in the morning so far?
Oh, and we also had another lecture on ketamine this morning. That was very
Good.
good. Practitioner out in California, Dr. Herman.
Mm.
Yeah, she was a cardiothoracic surgeon. Cardiothoracic anesthesiologist
Right.
who, during the pandemic, started getting interested in breath work, and then did a total pivot into providing ketamine-assisted therapies.
Awesome.
Hmm.
Sounds like a good conference, huh? Sounds good.
Yes. Yes, I'm very happy with how it's going.
Yeah, good. The students are, it's just all DO students from the school? Is that what it is, or?
Well, we've actually had guests. We have lay persons, a wide variety of medical practitioners, a lot of attendings tuning in from
Mm.
our institution, and students from some allopathic schools as well. We even have a student presenting from Saudi Arabia later today. So technically international, definitely international. You're in Colombia, she's in
That's
Saudi
right.
Arabia.
Oh, this
Yeah.
is international. Yeah. So my
Okay.
throat is a little dried up.
So it's about 2 p.m. Um, um, so I will introduce you and then you'll be able to share your slides. So welcome back, everyone. I hope you had a nice lunch. And it is now my honor and pleasure to introduce Dr. Joe Tafur. Joe Tafur is a Colombian-American family physician, originally from Phoenix, Arizona. After completing his family medicine training at UCLA, Dr. Tafur spent 2 years in academic research at the University of California, San Diego Department of Psychiatry in a lab focused on mind-body medicine. After his research fellowship over a period of 6 years, he lived and worked in the Peruvian Amazon at the Traditional Healing Center, and you'll correct my pronunciation,
Niue Rao. Niue Rao.
Niue Rao, Centro Espiritual. There he worked closely with Master Shipibo healer Ricardo Amaringo and trained in Ayahuasca curanderismo. In his book, The Fellowship of the River, a medical doctor's exploration into traditional Amazonian plant medicine, through a series of stories, Dr. Tafur shares his unique experience and integrative theories. He is also a co-founder of the Church of the Eagle and the Condor, a multicultural spiritual community currently seeking permission to practice sacred ayahuasca ceremonies in the United States. Thank you so much for being with us today, Doctor. You have the floor.
All right. Well, thank you very much, Jesse. Thank you to everybody for being here. Hey, this is the group, right? This is who's here. I can't see everybody, or maybe not everybody has their video on. Is that how it is? I just talk to you.
Yeah, so we have the panelists, kind of the people running the show up on screen, and the general attendance is invisible.
Okay, very well. Well, yeah, thank you for having me. It's an honor to be here, to be part of this conference. Sounds really exciting, really cool. I'm happy for you all that you're doing this. It seems like there's just so many things popping up. I went to UCSD medical school, and somebody just sent me something from there, a video, like an hour-long video of like new treatments for depression that the faculty is putting on to share about what's going on. Then it was like ketamine, and it was whatever they call the transcranial magnetic stuff, and psychedelics. So you all coming out of medical school, like at the time when all this is happening, like this is very close. I mean, ketamine's available, that's real, and like we said, ayahuasca and the plant medicine and the other traditions are around to try to help inform and share, and we are trying to. I am part of a movement that's trying to get our own sacred ceremony acknowledged and given permission, as there are 2 other spiritual communities, churches that practice with ayahuasca. So I'm going to break into my slides here. I was asked to give this talk, so we came up with this title. It's pretty, let's see, share the screen, trying to share the screen. Told me to open system preferences. Let me see. Share, grant access, and so I open system preferences to try to grant access. I don't know how to do that. Let me try. Well, anyways, I'm going to get my thing, and the title is pretty exciting. Any ideas where I would go to open this in system preferences on my Mac? I know you all have my slides. That's another option.
Yes, I can pull it up if you'd like.
You want to just pull it up and I'll just say like next slide? Is that all right?
Yeah, that's perfect.
Okay, let's do that. And let me see what I got on. I'll pull up mine up just so I can see a little bit. Because the title of the talk is The Mechanisms of Ayahuasca as a Therapeutic and Ritualistic Agent in the Treatment of Mental Illness and Psychosomatic Syndromes and Spiritual Injury. So pretty exciting title there, a lot there. So I'm gonna get into ayahuasca traditional ceremonial use, which is one of the roots of this psychedelic psychotherapy culture, is this ayahuasca traditional culture. I'm in Colombia right now, so I'm here with my friends. They run an organization called Cultural Tras la Huella. They just did ceremony on Friday. We're doing ceremony tonight. It's fully legal here, by the way, and it's highly respected. So let's go to the next slide. Is that working? I'm landing in the background here. So there's you already heard about this, that he gave you my bio, but Shipibo is the culture that I work with in Peru and the Amazon. So Shipibo traditional Amazonian plant medicine, which is a big, broad field like traditional Chinese medicine. I mean, there's many different subsets within that. There's body workers and just pure herbalists for medical kind of herbalism. There's there's midwifery of some form, and it goes on. And then there is the, curanderismo, which has been called in the West like shamanism, which they would refer to in Spanish, curanderismo, and it kind of refers to spiritual healing. So this kind of blurs into the world of mental health and what they call down there Amazonian psychiatry. So I went through the apprenticeship with my teacher to learn to run ceremony, traditional ayahuasca ceremony. And these are my websites. I actually have an online class based on my book you can check out on modernspirit.org. We're starting up in April if you're interested. And then I got my website, and then the Church of the Eagle and the Condor if you want to learn more. Next slide, please. I packed in a lot of slides here. We have an hour. I heard I have an hour and then a half hour for questions. So I just wanted to really throw a lot at everybody. And maybe you've heard some of it before. I don't know. But this is, I put out this book, Fellowship of the River. The goal, among other audiences, is that medical students read this book, that people that are learning medicine read this book. And it's a book about, it's a book about acknowledging the emotional and spiritual dimensions of illness. Gabor Mate did the foreword. And the book is about my journey after residency in family medicine and deciding to go down to Peru and getting really involved down there. And then it turns into, as I get involved in a healing center, to presenting cases that me as a doctor, as a family medicine doctor, are very familiar with what kind of cases we struggle with in Western medicine. Maybe with osteopathic manipulation, you can make some gains with some of these people that we weren't getting with, surgery and drugs and things like that, therapy. And so I wrote about it, and it's a book about that experience and about my theories on bridging, some of these emotional and spiritual approaches to modern kind of therapeutic approaches. Next slide. So it's also in this, I'm part of the spiritual community called the Church of the Eagle and the Condor. And just a comment on this time that we're in that I just mentioned, where you're all coming out of medical school and these things. This is the kind of talk you're hearing. And this didn't happen when I was in medical school. And it's this time that we're in right now that's been acknowledged by a lot of different people. They're saying, members of indigenous and modern cultures alike realize we are living in a time of tremendous transformation for indigenous cultures in the Americas. There's this prophecy, that's part of this revolution. Tells a time of, it has all different versions of the prophecy. One of them is when the people from the north and the people of the south, so you're in New Jersey, they're in New Jersey, I'm in Colombia right now, they awaken to the realization that they are more capable of consciousness, love, and awareness when unified. In American shamanism, the union of the people is made possible by the parallel spread and unification of the ancestral medicine. So this timing that we're in, it's also interesting because ayahuasca began to spread, for instance, out of South America in the last few decades, going right along with the way this prophecy had been laid out. Next slide. This is my teacher, Ricardo Lamaringo, here with the Niuerao tree. He mentioned the name of the center, Niuerao Centro Espiritual. Niuerao is a Shipibo name for this sacred tree that the center is named for. It's this grove that's there. That's why the center is there. On the left, we see this Shipibo imagery called Kana in Shipibo. It's the designs, the visual designs of the plant medicine of the ayahuasca and the other master plants that people see in the visions. And many people see these in the visions from all different cultures, and then they're translated into this embroidery. So that's a little bit of the tradition. Next slide. That's the center there, that little patch. It's on the edge of a gigantic national forest in the Peruvian Amazon, about an hour and a half outside of Iquitos, Peru. So in 2011, we started that healing center and started bringing people out there, foreigners from the United States, from Europe, from all over, to go into retreat and have traditional healing for a variety of problems. Next slide. So this is us we drove medical students there. I used to lead groups with, there's a naturopathic school in Arizona, SCNM. So this is 2013. Us bringing a bunch of naturopathic students to come down to go through a 10-day healing experience with the Shipibo healers there on the top left somewhere, Ricardo in a black jacket, Wheeler in a red, two Shipibo master healers. And so they're going to walk people through a healing experience, and then in the tradition, to learn the medicine, you have to go through the healing experience. It's the same process. To learn to become a healer, you just go through a longer version of the healing, and that's how you learn. Next slide. So interesting times. This Eagle and the Condor prophecy time, when all these things are happening. Naturopathic students are coming down to Peru to get healed. I'm broadcasting from Colombia to talk to you. Next slide. And so this New Age brings this re-encounter of all the elements having suffered separation during humanity's prior unfolding. It becomes a time of coming together of peoples, ancestry, and traditions. Next slide. So in the book, I released this book in 2017, and I talk about, this experience that people are having with traditional Amazonian plant medicine. They come to the center at Niuerao. They go through a process. They have a 10-day retreat or a 2-week retreat or 1 month or 2 months or 3 months or longer, depending. It's open-ended. They don't limit it. It depends on what the person might need. The first, it is regarded that they need a retreat. Like just in an hour, just in 15 minutes, you're not really going to make that big of an impact. I guess you hope somebody's going to make some lifestyle changes or something, when they go home. But then the idea is that really for this kind of healing to happen, a lot of traditional cultures believe you kind of need to take a pause. So these people come down and they're in this retreat, and so they're doing this dieta vegetalista. So in the Shipibo culture, to receive ayahuasca and master plant diets, which is like you're taking a particular plant every day while you're on this strict diet for 10 days or longer, and then that's guiding your healing. And then inside that process, you're going to do some ayahuasca ceremony with the healers. And so that dieta for them is just, it's been given to them by the forest, by the plants themselves. Like you don't eat salt, you don't eat sugar, you don't eat fatty foods or oily foods, you don't eat red meat or pork, no dairy, no spicy, no sex, no drugs, no alcohol. Very limited, very kind of simple. And the idea is that it's going to help you open to the ayahuasca, help you to sensitize yourself, and also to get more from these plants you might be taking. So then you go to ayahuasca ceremony. In the ayahuasca ceremony, you don't need to drink ayahuasca. The healer is going to drink. They drink ayahuasca to guide their work. And then you have the option. The one thing you have to receive while you're in Niuerao is Ícaro, healing song. So then the big focus of the ceremony is healing song that's going to be performed individually on each patient coming through to help them work through their issues. So I say, these people, I describe in my book, I just have these anecdotes of these, I think it's 10 or 11 cases, something like that. They achieve both mental and physical healing through these very spiritually oriented techniques from the tradition. Next slide. So this is the list of the cases that I present in my book. As I said, as a doctor, family medicine doctor, these are the kind of things that just come in and out the door, not making a big difference with. There's not much that we do for some of these people. And as a family practice, as an MD, you just send them to the psychiatrist, or then the cough to the pulmonologist, or the Crohn's disease, to the gastroenterologist, to the psoriasis dermatologist, et cetera, migraine to the neurologist. So very different kind of approaches, or at least different medications or ideas. But within this thing, these people all got the same kind of treatment. Different plants, but mostly the dieta, the ayahuasca, the ceremonies, and then some master plants underneath. And they had similar treatment, and it was effective in these diverse cases. So I say, well, it must imply some kind of common physiology, right? Just like in pharmacology or whatever medical thinking we're in. That's if it works on different cases, then I guess those different cases have something in common. Next slide. So, how do we understand what that is? Well, I say, well, the patient is the bridge, because people are like, well, how are you going to connect, Amazonian shamanism with Western medicine? And it's like, well, a lot of people want to just play that game and be stuck in some kind of cultural, I don't know what it is, Stone Age, I guess I would call it, because it's like, yeah, they're human beings in the Amazon. They are human beings. And when they greet people coming from other countries, they recognize them as human beings quite readily. And they start from there and they work with each other. And you don't have to be from the culture to have your life changed by healing song. And the proof is this growing ayahuasca tourism industry in Peru. Whether people think that's right or wrong, to have such a business, but then they're running hospitals and clinics, aren't they? So I say the way to understand how these things come together is the patient is the bridge. So we follow the patient's experience through that. You ask we know what the doctor said was wrong with them. We know what the patient feels is wrong. Then we know what Ricardo, what the curandero is saying. I think this is what's going on. Then we follow them through the process. And then if they got better, then we look at the other end and see what happened. And what do the doctor's measures show now? And what does the healer feel about it? And how does the patient feel? And so there's this mind-body, right, pair that we talk about a lot now that's making its way into all kinds of medicine, mind-body, mind-body. And then there's another pair that Ayurveda talks about, that Chinese medicine talks about, that native indigenous cultures from the Americas talk about, of this emotional body to the energy, to the spiritual, we would say. It's kind of like a touchy topic for some people who are a little traumatized by their religion, but we're talking about energetic, this, like I say, how could I describe it? As real as heartache, as real as joy, that department there, the way emotion is connected to these realms that kind of go beyond. Next slide. So this is a little drawing that I have based on that I do for my online class, based on the ideas presented in the book, and it just shows how here's this healer, Shipibo healer, approaching somebody energetically through their song to reach their energy body within that philosophy, in that context. But then what ends up happening, where it comes over to the Western side, is they approach them through their emotional being. The person has very emotional experiences in this process. And the emotion is kind of like the bridge between mind and body. And then I go as far to say that the emotional body that some of these different cultures are describing, I think we already have described, a very related network, which is from my time at the Mind Body Lab, is psychoneural endocrinologic immunologic, whatever it is, psychoneuroendocrine immunology. Okay, PNEI, psychoneuroimmunology, and then it started psychoneuroendocrinology, and then out together, psychoneuroendocrine immunology, which is this system, right? The PNEI network that I'll describe a little bit to you, but that's affected by emotional trauma, and it's affected by emotional healing together as a constellation. And then those things, like you can see where they kind of exist in the material and the allopathic world. Though you said, well, we talk about trauma. Okay, trauma makes its way. The shaman understands trauma when you say trauma, and everybody knows it's not just as simple as molecules. Stress, same kind of topic. But then we have allostatic load. We have these topics of like the way stress and wear and tear affects the physiology. And we have growing data around that. The way neurogenic inflammation is like that your own nerves can create inflammation in your skin and psoriasis, in your gut, in Crohn's disease, in your brain with migraine headaches, that is generated not from some environmental insult, but apparently from some kind of emotional disturbance in many cases. And then the way that epigenetics could be playing a role in all this. So next slide. So the book and my experience there is all about this re-encounter with spiritual healing, like I was talking about with the eagle and the condor. So we're treating the seemingly invisible elements of our experience. This is what these people, why did they leave their culture, their system? They were in Europe, they were in the United States, they have money to go to the doctors, they have money to go to Peru. They've tried a lot of stuff, all the cases I present, they went to the doctor for a long time, they went to the psychologist. We're not against that, I'm not against that. It's just they were going and they weren't making progress. So what did they find in Peru that they didn't find back home? What's missing in our system? What could they benefit from? What could a lot of people benefit from? Which direction could we perhaps expand our system? Well, they treat the emotional experience and they treat the spiritual experience. And how do we call spiritual? How can we think of that in secular terms and universal terms, the way mindfulness is describing it? Okay, the way gratitude research is coming along, the way compassion research is coming along, that's showing measures, physiologic shift. Similarly with forgiveness, like that realm that was previously the area of, religious or spiritual, practice for millennia. So our sense of meaning and purpose, our belief system, addressing those things directly as they may relate to some of these illnesses. Next slide. So this is, where do these emotional and spiritual influences touch the flesh? I mean, if they are real, and that's what the big, argument is about. Well, if they're real, how come we can't see it? How come we can't measure it? How come we can't, blah, blah, blah. Okay, good question. That's fair. But maybe we know enough now. Maybe our measurements are have extended that far. And so I say, well, related physiology and the biochemistry, I say, well, it's an emotional body, the one I started talking about. And I think the epigenetics is one of the other areas. that we might see some evidence of this. Next slide. So the patient's the bridge, illuminating the intersection, I say, the intersection between biology, emotion, and spirituality. So that's what my book's about, Fellowship with the River, and that's what I'm going to try to talk to you about. Next slide. So here's the emotional body. So like I said, I was at this mind-body research lab under Dr. Paul Mills, who's now the research director for Deepak Chopra. And this is psychoneuroimmunology, what they call mind-body research, or a lab where they study the way stress affects the immune function, the way stress contributes to hypertension, the way depression, delays wound healing. So these are the kind of things that were being worked on and continue to be worked on. And they kind of illuminate. There's this in the brain, there's the limbic system, the emotional processing region that's wired directly into the autonomic nervous system, with the sympathetic and the parasympathetic. And then that's plugged into multiple regions of the immune system. Next slide. Next slide, please. I think we missed one. Can you go back one? No, I guess not. Okay. Anyways, the other slides that I think I missed but I'll get into it here. Next slide was the endocrine system, which you're aware of, most of you, okay? And the a picture of, and here's an element of it, of the autonomic nervous system. So as a core element of the P9 network, we have the HPA axis, right? The hypothalamic, pituitary, adrenal axis, fight or flight response, stress response system, controlling cortisol levels in the body. This is an area that we know that emotional trauma impacts. People with PTSD, they have issues with their HPA axis. Okay, that's a reality. So this invisible realm of trauma, even though they may have had something really intense happen to them, or they saw something really intense, but how does that turn into something in their body that stays with them? Well, one of the evidence points is this HPA axis dysfunction. So these, I just mentioned all these different areas where the HPA axis is altered as an element, a core element of the emotional body, and the way emotional trauma affects the stress response system in PTSD. Next slide. Just little examples of research that came out around this, examining the crux of autonomic dysfunction in PTSD from a psychosomatic journal not too long ago, endocrine aspects of PTSD and implications for diagnosis and treatment. Pro-inflammatory milieu in combat-related PTSD is independent of depression and early life stress. So the combat itself somehow creates this pro-inflammatory milieu in these people. So we see an example here of multiple elements of the PNEI network altered by related trauma, the emotional body. Okay, next slide. So the big news, and maybe you've talked about it in the last couple of days, but the MAPS MDMA assisted psychotherapy trial for PTSD. First published their work in 2011, and just the incredible results that they're getting with people. Really turning things around when they bring the MDMA, which they're considering a psychedelic element, and then creating this therapeutic environment, which is pretty wide open, as I say over and over again, like to be on the MAPS team, of one of the therapists for the MAPS team, pretty graceful human being. Like a lot of people would regard some of these individuals as quite spiritually oriented, quite open-minded, quite open-hearted, and, have done a lot of work themselves, as they say. So that's what's guiding this, so the MDMA obviously plays a role, but compared to all the MDMA being consumed all over the world at parties and festivals, et cetera, they're not getting anywhere near where these people are getting, and sitting with people, not for an hour or 2 hours, but for 6 to 8 hours. And what happens, after the third hour or the fourth hour? Next slide. So they keep publishing, like they're breaking in 2018. They're now working with, conservative elements of the society, military vets, firefighters, police officers. Just last year, I think the study made the New York Times. They think the MDMA is going to be legal for prescription next year, I guess is the latest thing I heard. Next slide. So PTSD and the emotional body. So we know that different elements of the emotional body, psychologically, there's the anxiety, there's nightmares, neurologically, just what I mentioned, this autonomic dysfunction, high blood pressure, cardiovascular stuff related to emotional trauma. Endocrinologically, you got cortisol disturbance, adrenaline disturbance as examples. immunologically this inflammatory disturbance. And there's all different degrees and research going into each one of these areas, including the neuroscience related. And so I'm just saying, look, it's this is a thing. So this is a disease of the emotional body. Then they put somebody through this psychedelic assisted therapy where they heal emotional trauma. And guess what? Like that's what goes on during those sessions. You know, that's what they're doing. They can't, that's not the subject of the research study and what they're publishing because if they're very conservative journals, et cetera, et cetera. But the big question is what is happening during those sessions and what's happening in the subsequent integration of those sessions. Next slide. So in my book, I talk about the guy, Russ, who's a PTSD Vietnam vet, you know, guy with PTSD since Vietnam. I took him down there in 2007, approximately, 40 years later. And that means he had a long time with PTSD. That means he went to the VA. They were not able to help him very much, you know. And then he goes and then he sees like I always say, he sees the young guys from Afghanistan and Iraq show up to the same group therapy that he's at. And they wonder, am I going to be here for the rest of my life? Like, do you guys know how to help us or you don't? I mean, maybe just tell us so we can at least get used to it or something like that. But now with the MAPS MDMA trial, there's a new hope. You know, we took him down to Peru. He had a massive healing experience in 10 days, you know. Things really turned around for him. He was healing, you know, from Ricardo's perspective, the healer, it's like healing the energies of trauma and war. And it wasn't just that, it was all the stuff afterwards and coming home and trying to like have his family fall apart when he gets home and trying to heal that and all the forgiveness work that he needed to do. And the way it just shifted things for him afterwards, as far as not really needing psychiatric medication anymore. You know, maybe a little medicinal marijuana he uses sometimes. His diabetes got better. His blood pressure got better. You know, he lost some weight. It's called holistic healing. Next slide. What about the biochemistry? Where are these energies? Can we measure it anywhere? What happens when we clean the energies, when he goes through this big thing and he's like, oh my God, I just got my energies cleaned out. And then everyone just rolls their eyes. Oh, whatever. Who cares? That's an anecdote. Well, I don't know. But then it's happening at the MDMA trial too. You know? Next slide. So in the book, I talk about this case with a lady who was coming down with migraines. So I'm learning the tradition. I'm learning how to work with people in the tradition, which means singing songs, singing Icaros to people when you're on ayahuasca and helping them through stuff and having visions, you know, and that's part of what guides this process and the work that we do. And I had a vision of this. Ayahuasca showed me her chromatin, the DNA wrapped up in the protein packaging, floating in that. It was pink in my visions. And then there was this little black dragon that was swimming through the nooks and the crannies on top of and over and around the DNA. And ayahuasca told me, that was my experience, said, Joe, her problem is not in her genes, it's on her genes. So then I was like, oh, what? So it's like epigenetic? Is that what you mean? And it just got me on this train of like, well, maybe it's the epigenetics. Next slide. Or it could be part of it. So there's a growing body of research and biology exploding, and you know, should hopefully be a big part of your education by this point. When we were coming out of school, it wasn't really known about this level of this dimension, you know, of DNA function. That's not just the code being transcribed and translated, but the translational step, and even the transcriptive step. Like there's a lot of environmental influence that allows for the incredibly wide variety of ways that any one cell's DNA can be expressed. That one cell is going to end up a red blood cell for its whole lifespan. Another cell is going to end up, you know, part of a bone in your toe, you know, and it's going to stay there and it's going to be like that. It's the same DNA. So it's programming. It's DNA programming is the way I like to think about it. And one of the ways that it happens is these methylation groups that can tag different parts of the DNA strand or even the proteins and affect the way that those things are able to be transcribed and the way they might be translated down their development. Turns out epigenetics has a huge influence, and like we see in the development in utero, there's a lot of stuff that happens epigenetically. Environmental chemicals affect people epigenetically. Drugs, pharmaceuticals, aging, diet, nutrition, diabetes type 2. If somebody that ends up having a disease, they think, is that a genetic disease? Look, their mom had it, their dad had it. And then you change their diet and then they don't have it anymore. Maybe they did pass on some risk of it. That's possible. You do see higher and higher, seems to be accumulating in the family line. There's other big areas of focus of epigenetic research: cancer, autoimmune disease, mental health, depression, anxiety, etc., diabetes. Next slide. So I never heard, when I was in medical school I graduated in 2003, no one ever told me that to think about stress or some kind of trauma or epigenetics, playing a role in migraine headache. But then this lady that I came to me, her issue was all about the healing that she had in ayahuasca with us. It was all about forgiving her father and letting go of all this energy that she took on when she was very young, and there was so much rage and screaming and yelling around her. And it kind of like, they say migraine is a problem of sensory integration. So that now the smell becomes this, the light is too much, the sound is too much, the taste of this is too much, and triggers this kind of cascade that turns into this big migraine, sensory overload. So then she's releasing all this stuff, she's letting go of all this stuff, and she's also like learning how to forgive her dad at some deep, like heartfelt, energetic, it goes as far to say spiritual level, where it's shifting things for her. So she did, her first time there was like 10 days. She went from debilitating migraine headaches that last like 2 to 3 days every time she gets her menstruation, requiring medication and can't do anything, to like a year out, she's had like taken 2 of her pills. Like that's it. Humongous shift in her migraine symptoms. I still talk to her. I talked to her a couple of years ago. She continues to do very well. So here's some studies, migraine, maladaptive brain response to stress, that this is a part of it. This is a contributing factor. Childhood maltreatment in the migraine patient, contributing factor. Doesn't always get looked at. Epigenetic mechanisms of migraine, they started looking at this in 2013. 2014, there's a little more exploration. It continues to be explored. So this was a real thing. The ayahuasca told me this. Is like, oh my God, this is real. This is what's happening. So maybe we're like healing her epigenetics. Is that what's going on? Could that be what's going on? Could it be helping, or could that level be involved? Next slide. So like I talked about, her healing down there, and was all about this deeply, spiritual experience, very emotional experience, and really learning how to kind of heal the wounds and traumas of her childhood and find ways to forgive and let go of, the pain that her parents, may have brought onto her, whether they wanted to or not. Next slide. So yes, Ricardo, what are we doing? What's going on? What's happening with these people? How did you do that? How did you heal these migraines or get them so much better in 10 days? He says, oh, estamos limpiando las energías. Like we're cleaning the energies. And people, when you sing Icaro, it's like soa. Soa means to clean the energy. Well, what do you mean? Well, the energies of our traumas, our strong experience, our strong emotional experiences. The way things that happen in utero when your mom is stressed out, it happens all the time at the center in Peru when somebody has an experience of seeing their mom when she got pregnant and she wasn't ready and it wasn't a good time and she was really scared and wasn't sure it was the right thing, and the way that kind of physiological response could affect the child in utero and other things going on, infancy and childhood. Like these are the focuses of epigenetic research, by the way. Adolescence, adult life, our environment, environmental influences from the epigenetics, from our relationships, and then even in the Shipibo thing, from our ancestors, from our family line. And yes, there's even evidence that epigenetics is carrying some of those things down the line. Next slide. So here's an example of that: is early life trauma. So you have this environmental experience of early life trauma, and then the person is having depression later in life. And then they see that the glucocorticoid receptor gene, the cortisol receptor gene, is affected. You can correlate, epigenetic changes or methylation changes related to that cortisol receptor that's related to the trauma that they had. And then that's then correlated to this depression that they're having later in life. the energy of this trauma being carried on within their system, a form of conditioning within the lifespan, and a dimension of the DNA biology that is, carries the possibility to be conditioned within the lifespan. That this is now true. Next slide. So you have ancestral trauma. So this is research coming out of up there in the Northeast, Dr. Richard Yehuda and her crew, showing intergenerational trauma, transmission of stress. So this idea of concentration camp survivors, that their kids are going to have a higher prevalence of anxiety and depression. And it's not just because of being parented by a concentration camp survivor. There actually are some epigenetic imprints that are linked to the original trauma that are being passed on. So this idea that the conditioning in many biological situations, you'd want to pass on some of the conditioning to the next generation so it would prepare them for the environment they're going into. And that this would actually be a big factor influencing what we think of as instinct. So then they did the same kind of stuff with mice. You do mice and you stress them out every time they smell a smell until they just finally are conditioned to freak out around the smell, even if they don't get shocked or whatever they do to them. Then their kids, multiple generations of the children, go into fight or flight response upon first exposure to the smell, having never smelled the smell and having never been conditioned that way. So that condition is carried on. That's like a form of conditioning. That's a form of ancestral trauma. It's also a form of instinctual adaptation to a new environment. So it's part of the normal biology, but then there's this maladaptive element when you start getting traumatized and stressed by things that you don't necessarily, doesn't benefit you to adapt to war. Next slide. So the epigenome, we know that it responds to antidepressants. We know that it responds to parental love, or at the very least, the lack thereof of that love. If you abandon monkeys and things like that, they leave epigenetic imprints, that kind of trauma. Meditation, altered states of consciousness are known to affect different aspects of the epigenetics, as well as psychotherapy, which are two places where nothing is happening. No one is getting touched or given a drug or anything. It's some kind of environmental exposure to the energy and the emotion and the altered state of consciousness. Next slide. So that's what Ricardo says. We got to heal those energies. We got to clean them out of these people and figure out a way to do it. And the epigenetics research is tracking all those same areas that are the focus of his work on people at the center in ceremony. Next slide. So I say we're psychedelic therapy. I'd say it's healing hearts and souls by healing the emotional body and the epigenome. Like those are two ways that we see these invisible energies of the emotional and spiritual, our heart and soul, the way we see things transition for people. We see their autonomic nervous system improve its function. We see shifts in the epigenetic, imprinting associated with trauma. Next slide. And that's the spirit behind our research project. My nonprofit, Modern Spirit. We have the Modern Spirit Epigenetics Project. We're tracking epigenetic shifts or changes, or at least DNA methylation changes in the people going through the MAPS trial. We wanted to do it with ayahuasca first, but it was too difficult, so we're doing it with MAPS. So the first publication is was waiting to be published, and we did find some stuff. Very small numbers that we have. We were kind of blown up by COVID, but we pursued and we did it anyways. And we have just the first 20 something like people. Like, well, we're never going to find something with just 23 people, and then we have. So there does seem to be something there. Next slide. So that's back to this again, this idea of all these areas being affected by our emotional being, our emotional life, and that maybe this energetic side of us that all the other traditions describe, that's a portal, that's a way to reach people, when they need help with this deep emotional trauma. And when we reach them that way, that can affect their physiology, actually. Next slide. So spiritual healing is spiritual practice. Spiritual practice is spiritual healing. So a lot of times we're like, well, this is medicine. Is this medicine or is this ceremony, Joe? What are you talking about? And it's like, well, any kind of spiritual healing for us in the tradition that we're part of in Peru, it is a spiritual practice. Like it's called Nihuerao Centro Espiritual. That means Nihuerao Spiritual Center. There's no doubt that is the focus of the approach. But all spiritual practice is supposed to be spiritual healing. It's supposed to be nourishing your well-being. That's the purpose of it. Meditation, prayer, all these things. It's not just to be doing it to follow some kind of dogma. Your body and your health should respond. That's how we know that it's doing its thing. So it can even have really profound impact on your emotional health and your physiology. Next slide. So in that sense, in the traditional way, song is medicine, love is medicine, prayer is medicine, meditation is medicine, ceremony is medicine. You can heal people from any number of things, if you know what you're doing with the right kind of approach. You can help shift their physiology. Next slide. Therapy is like having, the origin of the word to minister. I guess it also means to treat medically. This is kind of like a dual purpose word. Like therapy seems to be very welcome in the Western world, but its roots have very spiritual overtones. Ceremony is a little more direct, but in like the traditional perspective of so many cultures, the path of healing is really about realignment with our divine essence. Like that's the Native American approach. That's why the world of spirituality and health and healing are so interwoven, because it's believed to be part of the same thing. Next slide. So in the MAP study, in the native cultures, like the groups that I work with, the Navajo groups, I'm down here in Peru with other groups, and they talk, a lot of them talk about this right relationship, like that's what health is right relationship. So when I'm in right relationship with myself, with my loved ones, with my community, with my society, with the ecosystem, the environment, and the universe, I'm healthy, and when I'm not in good relationship with myself or with my relationships with my loved ones, like my inner child, like it's going to affect my health. And so the way that plays out in this modern thing is you have this overlap, like what you're all part of right now, is you have this therapy medical model like the MDMA, the MAPS trial. But the MAPS trial in their protocol that's FDA approved, one of the major goals of the training is to help people connect to their inner healer. Like they have to allow a mystical element because they're going to rely on that. A big part of, I've been through the MAPS training, a big part of it is guiding people back into themselves, to this inner healer, to some kind of source that's going to guide their process, which is also the focus of spiritual ceremony. Next slide. So Rachel Harris, a good friend of mine, she wrote this book, Listening to Ayahuasca, A New Hope for Depression. So I've been mixing psychedelic psychotherapy with this ayahuasca. Now the talk is about mechanism of ayahuasca, but it's very interrelated. Okay, like there's the same kind of, and I'll touch on that, the mechanisms. You're seeing the same mechanisms at play in many of the same different approaches, but same mechanisms. So she has this thing about new hope for depression and addiction, PTSD and anxiety, which is like, that's a big focus of a lot of psychedelic psychotherapy. Next slide. So she published this research study in 2012 that she says ayahuasca guided her to run the research study and to eventually publish it. And they were comparing North American ayahuasca ceremonial retreats to Catholic weekend retreats to see where is it as spiritual by known academic measures. Are they comparable as far as spirituality, accepted academic measures? So something that's clearly the Catholic retreat as clearly of spiritual focus, and then this ayahuasca retreat where some people are going for therapeutic reasons, but then I guess some people are going to Catholic retreat for therapeutic reasons too, as it turns out. So they compared them and they had these different questionnaires after the spiritual experience questionnaire and checking these different factors, joy in life, relationship to the sacred and toxic feelings. Next slide. So the key finding strongly supports the view that ayahuasca users are engaged in an authentic process as spiritual in nature as that of the retreatants. If you talk to Ricardo, he's like, yeah, that's of course. And I'm a doctor, he'll say. Soy médico, medicine man. That heals heart and soul in the spiritual context. That yes, people are going to have some of the same kind of experience that they're going to have at the Catholic retreat. Next slide. So then you have the neuroscience of all this, and some of the breakthroughs that coming out of Robin Carhart Harris' work that he was previously, I think, at the Imperial College of London. And so this default mode network was an initial thing that a lot of people were learning about. This neural network in the brain that they're saying could be a neural correlate of the ego. That like a lot of your rumination, a lot of your autobiographical processing, when you're thinking about the future, when you're thinking about the past, when you're thinking about thinking, when you're disengaged from your senses and the moment, you know, you're in there ruminating, and the default mode network is more active, or certain parts of it are more connected. And that perhaps this, they suggested in this paper, they're looking at brain entropy, actually, like more entropy of the brain in a psychedelic state. When they give them psilocybin, this default mode network starts getting less connected in a different way, or yeah, I didn't think that's a way to put it. And then the entropy in the brain goes up, and all these other wild things start happening. So this ego, this default mode network, is maybe suppressing consciousness to a more grounded, kind of workable level for the human being. But maybe there is some primary consciousness out there that's big and beyond. That's actually what's really going on. And so we're getting this kind of secondary, and that this default mode network is pretty susceptible, it seems, to a lot of conditioning from life. So beyond the epigenetic level, like this neural network level. Next slide. So they talk about how the default mode network is to be suppressing to secondary consciousness, and this entropy going from very high to like where it's like your brain function is unstable, you know, crazy, psychotic, manic, or maybe just feel really high, or people are having big mystical experiences, or maybe they're just very optimistic and open-minded. Then you see this connectivity get a little too tight, or start to come online and bring down the entropy, and people fall asleep, or they go into coma, or while they're awake, perhaps they're more narrow-minded, having a harder time getting out of repetitive thinking, stuck. There's a dog barking out here I can't deal with. Hopefully he'll stop. I'll close the door, see if it helps. So narrow-mindedness, leading to pessimism, stuck in thoughts about depressive thoughts, fear, sadness, everything sucks, nothing can get better, I'll never feel good again, stuck in your mind. And then something helps open that conditioning, gets you away from this kind of guarded scarring or whatever is accumulated in there, and you have a new opportunity. Next slide. Ayahuasca has also been shown to alter the default mode network in ways similar to psilocybin. Here's the some images from their research, and you see these changes. Turns out when you do this to somebody, and the default mode network does this thing, and they get into this more brain entropy, quite often, according to Johns Hopkins research, they have a mystical experience. So this experience of primary consciousness opens them up to some kind of connection to something that goes a little bit out of the bounds of the normal, 3D discussion. Next slide. So this is just a busy slide, but it's just to give you an example of the mystical questionnaire, the mystical experience questionnaire that they use to try to assess how do we create secular questions about, these things. So they see, well, did you experience a fusion of your personal self into a larger whole? Did you experience a unity with ultimate reality? The feeling that you experienced eternity or infinity? Experience of oneness or unity with objects or persons perceived in your surroundings? So this oceanic boundlessness, so you're just asking these people these questions, just the way you ask them a depression questionnaire, and that becomes a, actually a clinical measure. So this is a clinical measure of like, how mystical did it get? And then they say that the more mystical it got, at least in Johns Hopkins research, that impacted tobacco cessation. These people, tobacco addicts, cigarette addicts, they had a deeply mystical experience that really helped shift things for them. Next slide. But it's not just that, because on the MDMA and the MDMA thing on ayahuasca, yes, people are having big mystical experiences. I've asked them in the morning. I didn't put the question here, but yes, they're pretty blown away, quite often. And but with MDMA and even the ayahuasca and even the psilocybin, it's not necessarily the mystical experience alone that's going to lead to the clinical change. And so with MDMA research, they're not getting that out of touch with time and space, but they're still getting these big results. So what is it? So they started seeing this emotional breakthrough. That emotional breakthrough, and they created a questionnaire that it seems like that is a big thing that's determining long-term response to psychedelics. Another important component, the mystical experience with this emotional breakthrough. Next slide. So here's some of the questions on that questionnaire. I faced emotionally difficult feelings that I usually push aside. I experienced a resolution of a personal conflict or trauma. I felt able to explore challenging emotions and memories. So like that, reporting that in a measure and what they went through in that experience is correlated to like long-term clinical change. So that's interesting, the role of this emotional aspect of ourselves that's connected to this mystical access. It's connected to how they feel. Like, how do they even know what they're feeling is through their bodies? That's how they sense these emotions. Next slide. And so then you have these spiritual well-being questionnaires that also are tracking. And so this, I didn't put the paper up because I didn't know it was published, but now it is published, so I could follow it up somehow to you all. But Adele de France is a friend of mine, and she's a researcher. And so they did a study recently, and it's all about like tracking these people who clinically responded to psychedelics and anxiety, depression, and eating disorders. So they have those people, and now they're going to track backwards and say, well, everyone that responded clinically, what can we say? What was a determining factor statistically for those people? And it turned out it was improvement in emotional processing by a measure that they have to determine emotional processing. So, okay, what about everybody that had emotional processing? If we track backward with the statistics, what was the determining factor? They had a shift in their spiritual well-being. So this idea that the spiritual well-being and the associated context is what provides the opening that's going to allow for these shifts in emotional processing, that it doesn't just happen on its own. That the context of the psychedelic session, or let's say the ceremony or the ritual, provides the environment for such a thing to happen. Next slide. So my book, I talk about it as like, this is metaphysics, this is energy moving. And I'd say, oh, these are the faculties of the soul. Like, what does it look like when somebody has these emotional processing shifts? Working with hundreds of people at an ayahuasca healing center in Peru, it looks like a lot of this, people finding their way back to self-love, people finding ways towards forgiving themselves, forgiving others, people increasing their capacity for compassion with themselves and with others, and then encountering gratitude and experiencing that at a deep, like tangible level within themselves, within their body, what it feels like to be alive. And so this work to me is a lot about this intersection between biology, emotion, and spirituality. Next slide. So back to ayahuasca, I mean, you could do, we're within its traditions. In Colombia, we've got, there's traditional healers here who are very upset about any kind of clinical study of ayahuasca. They don't think it should be brought into that realm. Although they say, yeah, there's therapeutic benefit. This is a sacred ceremonial thing. The reason they don't want to see it brought into that realm, because they're like, well, we know what happens. The only reason you do that is to commercialize it. That's what that's for. That's how your culture works. Like we don't agree with that. You shouldn't commercialize this. This is more sacred than that. Nonetheless, people want to study it, and they do study it. And so in Brazil, they've run a few studies, and this was just giving people ayahuasca without any ceremony in a clinical setting in a hospital room, hospital bed, and checking how it would help people with treatment-resistant depression in one dose, and they had some positive, results. This is the first controlled trial to test a psychedelic substance in treatment-resistant depression. Overall, the study brings new evidence supporting the safety and therapeutic value of ayahuasca dosed within an appropriate setting to help treat depression. Next slide. That was 2019. But just a year later, they start publishing on traditional ceremonial approaches. So they're getting people, healers, to agree. Okay, what do you want to study? Say, oh, well, we want to see this grief, loss of a loved one. We're struggling with this in our healthcare system. We know this deeply impacts people. This deeply impacts their mental health. It can impact their physical health. How can we help people with this grieving process? So they brought them through the tradition in the Maloca down at Temple of the Way of Light in Peru and in Iquitos. And they said, yes, they found statistical evidence that ceremonial use of ayahuasca has therapeutic value by reducing the severity of grief. Acceptance and decentering are both psychological processes that mediate the improvement of grief symptoms. So traditional approach in the ceremony, following, as they would say, the Shipibos, the guidance of the plants and the forest themselves. Next slide. So they continue to publish at the Temple of the Way of Light. Now they have the Spiritual Well-Being Questionnaire. They show, our results suggest that the indigenous should be healing work with ayahuasca has value to improve long-term well-being and quality of life for Westerners, including these measures, which in the other research is being linked to improvement, that this would be causal. If we can improve their spiritual well-being in such a way, we're going to improve emotional processing. And that's going to lead to symptom change and these clinical outcomes. Next slide. So I say spiritual well-being, like from a native perspective, manifests in emotional health. Like that's where we can talk to each other. Okay, let's talk about emotional health, the people who don't want to talk about spirituality. Next slide. Because emotional health has a physical body, it's there. Last slide, busy slide, just throw it at you, or last concept is this idea that's coming out of Johns Hopkins. Very interesting, at a Gold Dolan's lab, where they're trying to study this critical window. So it's this idea of like, okay, if people are conditioned and they're locked into this like pattern from their trauma or from whatever it was, and they're studying mice, neuroscience, they condition them, they get them to a place where their social brain doesn't work that well, just like a traumatized child, like what do they call it? Adverse childhood experiences, ACEs. You hit them hard enough when they're young, when they have this open window of neuroplasticity to learn language, to learn this, to learn so many things, to be a sponge. And then that kind of closes up as they get older, and then that trauma stays with them, until we find a way to reopen the window again. That's what Johns Hopkins is saying. They say they can do that with MDMA. They can get these mice to reopen this window from their traumatized little lives that allows them to re-socialize again. So saying this window is really where it's at. It's reopening this window. I'm saying, and I'm talking to them, I'm like, well, it's interesting when you open that window, just by the way, some people have mystical experiences, some people have these like deep emotional experiences, there's something else going on. But yeah, at the physiological level, there's something there. So their big thing is different, the longer, what she told me on the phone one day was like, the longer you're under the effect, the longer that window is. So ketamine is just a brief, you do break into the critical window. But then, psilocybin, 8 hours, or, MDMA 6, 7 hours, whatever, it goes on and on, peyote ceremony all night. That window then extends afterwards, this kind of afterglow period. And that's when the intervention, they're saying that's when you have that chance to intervene and make a difference in the case. That's the time. That's the integration. The effectiveness of the integration has in part to do with this neuroplasticity window that's open. Next slide. So I'm in Arizona with our community connected to Navajo culture and membership. And so the way they talk about it, compared to the psychedelic approach to the clinical approach, set and setting. How do we enter the thing? How's everybody's minds? How do we set up the room? Are they listening to music? The session itself, what happened in the session, and then the integration of that session. The afterglow, the period afterwards. We're going to try to strike while the iron is hot, and take advantage of this new plasticity to recondition the individual. In Navajo, you say, the way you get ready for ceremony is love. Set everything up, the ceremonies with love in your mind, love in your heart. That's how we do it in Peru as well. That's how we don't have to come up with all the acronyms. Another new list of acronyms for the medical students. Did you do this? Did you do that? Did you do this? Did you do that? Did you do this? Did you do that? It's like, maybe simplify it so you don't have to write everything down. Do it with love. Next, the session itself, that's called the gift. That's the gift. That's the gift when we're open, to the spirit, to things that were beyond what we could see ourselves by ourselves. And then afterwards, the integration, that's called the responsibility of the gift. If we don't apply what we got exposed to, what we learned, we don't explore it, then it will wear off. All kinds of ceremony. So they treat you in Navajo, when you go through big ceremony, it doesn't have to be psychedelics or peyote, just a big spiritual ceremony. It could be an all-night prayer. If you were 4 days, or this, a puberty ceremony, they do like 4 days. After that, they say they treat that person like a holy person for 4 days or for 1 week. That person is not supposed to work. They're not supposed to do stuff, you know? So they just have time to work through it. In Shipibo land, you do the diet. You know, you go there after ceremony, you don't get back in your car and go back to whatever you got to do. Just go back to your tombo in the middle of the jungle and sit with yourself for days and days and let yourself work on it. So having that space afterwards to really make the most of it. Next slide. So that's my talk for you right now as we go into the questions. Amazing timing on 1 hour, nailed it, incredible. Gracias, Iraque and Shipibo. Hey, I don't know how to say it well, but in Navajo, you know, here's my two Navajo friends, Naomi and Belinda, offering gifts to Ricardo Maringo and the Maloka Niwerao, saying thank you for teaching Joe to bring ayahuasca up to us. It's helping us, you know. So that's what's going on out here. And I think to me, like it's the psychedelic psychotherapy, I'm wide open to it. Ketamine, we're doing a ketamine project in Arizona with, it's called the Reciprocity Project, people who want to give back to the indigenous culture, to the ancestral culture for all this thing that we have, and they don't know how. And so they will give us some money and we'll pay for Native Americans to do ketamine assisted psychotherapy. And that's what we're doing. And so that's happening. So I just, you know, trying to help people figure out what's the best way. So thank you for all that. And I'm available for questions.
That was incredible. Can you hear me okay now?
I can hear you.
Okay, wonderful. So there were a lot of questions in the chat, lots of hearts and support coming up.
I should have. I didn't miss. I mean, I could have responded in the time, but we'll go back.
It's perfect. I've got them all listed here. Tried to organize them a little bit too. So the first question is, where can we learn more about traditional herbal medicines used in Central and South America? For someone who's totally naive or perhaps a middling amateur, is there any sort of compendium that you recommend or resource that we can dive into?
I think there's just so many different things out there. So it really depends on what you get exposed to and what comes your way. So we have like my online class is one thing, you know, that's kind of set up for medical people called the River Course. Then we have our thing, the Church of the Eagle and the Condor is putting on these cool webinars. We just had a Navajo elder, Josie Begay, is an incredible, very intelligent, extremely graceful human being, just walking people through stuff. So we're going to do a 3-part webinar with her. That's going to be on churchoftheeagleandcondor.org. I'll put those just there. So those are 2 things, you know. There's like so many different ways. And to me, it's like these kind of traditional ways, it's more personal, you know. So it's kind of like, okay, you meet somebody and then they guide you to something and go with that. You know, if you know somebody in your area, then learn from them, ask them. So there is a personal element to it that's really important. You know, there are books out there that are out, you know, written about these things. And there's just, you know, I would say one great book that is really worth reading is Braiding Sweetgrass. I'll put it in the chat right now. Braiding Sweetgrass is a very cool book that I'm reading right now, and everyone's been trying to get me to read it forever. And it's a lady she's a biologist. She is like an ecologist and a botanist, and she's also I think it's Potawatomi, like of the Great Lakes tribes. So she's teaching, you know, USA Native American culture alongside the science and walking people through that to get exposed. I think that's an amazing summary from a very bright person of a lot of Native American philosophy around health and healing and spirituality that I think bleeds over into, you know, this immense world of Native American culture that I'm like down here in Colombia. I'm at my friend's place right here, Xochipukuru. This is her project, Cultural Tras la Huella, which is awesome. And so they have all kinds of things they're putting out, and they're going to try to get translated these videos into English so people can learn from stuff. So those are ideas, you know, that's not everything, but those are some ideas for you.
Definitely something enough to get us started. So a kind of scenario, we have made it to attending status and a patient walks in and says, hey, I've got a personal connection to someone providing ayahuasca ceremonies. I've decided I'm going to do it. Is it physiologically safe for me to do it? And then I guess that leads us to the question, what are the medical contraindications to consuming ayahuasca?
Sure, no, that's a great question. So medical contraindications of ayahuasca that everybody should be aware of is that you have people just coming through your world, like you said, that they're going to tell you, and how are you going to react? two big ones are okay, mental health side. So bipolar and schizophrenia, somebody with a previous manic episode, like a serious manic episode or a psychotic episode, like they're at high risk. I've seen it happen. Ayahuasca is uniquely powerful. Like some of the other psychedelics can do it too, but I think ayahuasca is particularly powerful in pushing people with previous history of mania into mania that may require psychiatric intervention, might be they get hospitalized.
Mm.
So that's a big one. So you want to be careful about that for sure. But that's not to say like trauma, anxiety, depression, PTSD. So it's just like some people, I don't know, there's these mixed picture. You run into these vets who are like, were they psychotic or not? Or were they just really, so those are gray areas. So that's something you really, as it's illegal, if something were to go wrong in that situation, that'd be terrible. So you're better off with ketamine or maybe finding some MDMA research or I don't know, that's my opinion. Um, that's one is the mental health concerns. And so then another is cardiovascular. So it could be an intense experience for people. And if they are at risk for a heart attack or stroke, people do have heart attacks in peyote ceremony and ayahuasca ceremony. And so you want to have them screened. So anybody that has like a serious, like, high blood pressure history or just kind of unclear cardiac history, it's like, well, it'd be nice to have them stress tested the way you would for surgery or something like that and see really how's their cardiovascular performance. So there's that. And then there's, medication. So contraindication with medication. Ayahuasca itself has a MAOI inhibitor, right? Monoamine oxidase inhibitor. So that is contraindicated with many drugs. And so it may not be as bad as people think because it's a reversible one instead of the irreversible. And there's Brazilian research saying, oh, we had people on antidepressants and nothing happened. So, but still, we steer clear of that. In Peru at our center, we don't do it, and a lot of people don't do it. So, antidepressants or anything that's serotonergic that could be triggered by MAOI inhibitor push people into serotonin syndrome. So you got to watch out for that. And there's other drug classes that have MAOI, contraindications that you just have to look at like any other MAOI type of drug. Those are the main ones, okay? That I
Okay.
guess saying.
So here's our next question. Can you please comment on how much you believe sitting in dieta plays a role in the spiritual healing process, independent of its impact on communing with ayahuasca?
Yeah, I think in the tradition, that's considered the most important thing. And so when people have long-term diets in Peru, they are not, they're discouraged from drinking a lot of ayahuasca. They like somebody's, this has been changing because the Westerner is so voracious and can never be satisfied. And so the shamans finally give up, like just fine. But the old way, like to learn our tradition, that when we open New Out, the way we used to do it with people is it's 1 year of dieta. And those people would drink ayahuasca once a month. And when they're done with that, they're ayahuasquero. They're ready to run ayahuasca ceremony or to be beginners. The point being, you don't learn it from drinking ayahuasca, you learn it from the diet. And so similarly, the healing is regarded to be extremely important, the dietary process. So that's another, like here, I'm here with Sochi's crew. They're into ayahuasca yake here in Colombia, but one of the other teachers is from a culture in the mountains by the coast in Colombia, the Arahuaco, and they're meditator. It's meditative. So they do 9-day sits. So it's the sitting, it's the meditation, it's the taking a break from everything to allow, which has similarly shown default mode network, impact and the epigenetic stuff. So that is also, does something similar. So in the tradition that I'm part of, people, the diet is more important than ayahuasca ceremony.
Could you please discuss kind of aspects of in ayahuasca ceremony, the group therapy versus the individual, and is this a community thing, or does it have to be in a community? Can it be one-on-one? Can it be?
Right.
Let's just start with that.
Yeah. So it's you can do one-on-one. First of all, there is private ceremony. There's even doing 3 healers on one, or 4 healers on one, or 5 healers. Gabor Mate describes openly, publicly, that he went down to Peru and they said, no, we need to work on you on your own. away from
Wow.
these people. We don't want use. And he just said, okay. So, having 4 people work on them in one night. And so that is this private ceremony is a real thing. I just feel like that person needs all the attention. That being said, doing group ceremony, community, like coming together, there's a lot of benefit from that. First, uh, each person, so let's say in our tradition where there's icaros being sung to the group, to the room, to the space, that's for everybody. And then when they're singing one-on-one to people, and not every tradition does that. Here in Peru and Colombia, you don't see that as much. Like it's more like a group vibe and like, the playlist and they're responding. I mean, it's different from a CD playlist because they're responding to the moment in real time. So obviously they hear and see what's going on and they're addressing it. But in the Shipibo tradition, then you're addressing that and then still doing individual work on different people in the ceremony. And then that individual work in this case is a song, and so that everyone's hearing that song, so that's also guiding their process. So it's seen as interwoven from the two things that they're mixed. And so, and then, the community, like we just did it, I just took a group down 2 weeks ago to Peru. And so then we have psychiatrists and doctors and psychologists in the group. And so there's a community there that's going to go through it together. So the integration sessions that we do in the morning as a group, it's a big deal. You have all these people to lean on and share and learn from their learn from their experience about how to go through ceremony and what they're going through. So there's so much to be gained from that, from the communal. And then there's just in their free time they're hanging out. Same thing with I've been to Navajo ceremony where it's like prayer ceremony where it's all night, no nothing, no psychedelics, just stay up all night with song and prayer. So if you start around 8 o'clock, by 3 in the morning, the group starts kind of like it's like late night after hours party zone. Things people start acting like how they don't usually act, right? Like
Sure,
all of a
sure.
sudden, whatever the rails come off, and if I was like, "Mom, I never told you, this," and say
Which
it
is,
in front of the group, and so that's a whole other thing. The community provides a kind of a network for some of these like experiences that they're too high voltage to handle by yourself.
mhm.
The community can hold the space for you to be who you want to be when you don't have the strength to do it.
Wow.
So that's the reason. And so there are group therapy MDMA trials underway, right, in Portland, VA at the VA. So it's people are, and so they're, those people I find that the psychedelic psychotherapy researchers are not trying to destroy ceremony. They want to learn from us. That's my experience over and over again. Okay, this happened in some ketamine session. I'm like, Joe, what, they started talking to aliens. What do we do? That kind of thing.
And that
So,
kind of
and
actually
that does
address
happen, yeah.
that does kind of address like what my next question was, which is where we have an idea of what the ceremony looks like in South America. I feel like the idea of what that ceremony will look like in North America is still developing. And when are we going to start seeing live music in MDMA sessions? And when are we going to start seeing group therapies?
Yeah. Well, they're talking about it, and so I've been in discussions like that where they're like, "Hey, would you come and sing Icaro to this ketamine group?" With another friend of mine who's a Peruvian kind of traditional ceremonial person. And we're like, okay, we'll do it. So I mean, that's just the whole thing of like the sound healers and the musicians that feel comfortable with that feel like they're trained for that. Like that's a whole thing, right? It's a whole like study to respond to people in that kind of space. So there's trying to bring that back, like, all these traditional forms of singing and music that have this, this element that has these amazing emotional and energetic capacity. So they're asking about it. And so when we do ketamine with these indigenous people that we're doing it with, that's part of what we're exploring because it's not within a study protocol. And the people I've been out to, for example, I can't even remember what it's called, but there's a big ketamine center with really cool people in San Francisco. And they have like rattles and feathers in the room, and they can do whatever they want in there. It's their private practice. And so if they want to turn off the music and sing to somebody, they can do that,
Mhm.
and it's okay. It's like if they want to talk to them, they can talk to them. It's the session. So within the MAPS protocol, of course, they have to, it's FDA approved, so they have to keep it very, narrow to get the study results, the statistics. Once you break out of this, once it goes, then all kinds of things are going to happen in there.
Mm.
It's the
So
study protocol. It's not, they're not overly close-minded, the people running the psychedelic research trials. That's my experience. So they would try it and they'd be open to it, but they have a study protocol.
yeah,
So once it goes that, then is it off label to turn off the CD player, or whatever, the Spotify, it's like you're on your own. It's like we're not following them into every psychiatric session either, right? There's a lot of room there.
Okay, next question. So we kind of touched on set and setting. This question kind of dives towards that. Do you believe that patients / receivers of medicine should have intentions at the outset of their ceremony or session, such as specific questions, symptoms, or ancestral traumas that they seek to resolve? Or is it better to have no agenda whatsoever?
We encourage people to have questions, for instance, in Peru, you don't want to be like stuck. I mean, if it goes in a different direction, it's like a dream, right? There's a metaphorical element. You may not understand like where it's taking you, but you set some intention in motion. And so one of the reasons to do that is because a lot of people come and they're like, they just have the standard like new age, I just want to be of most service, find my highest purpose. And it's like, okay, that's cool, and it's very pleasant, but it's not very vulnerable. And so sometimes, and you don't have to tell everybody, it could just be for yourself, or maybe you tell the healer, when you approach it with like that kind of humility, when you say, because everyone's like, well, nothing's wrong with me, so I just want to see what it's like, I'm just they're like, I just want to talk to the spirits, and it's like, okay, but probably there's something that bothers you in life, like everybody else. And so just thinking about letting that, if you open that little window, it's like different, right? It's like when you're getting to know somebody and you get close enough with them that you tell them this thing you don't usually talk about. It's a whole different vibe. So they teach that that's the same with the plants. When you open yourself to that vulnerability, then it opens the door. It says, and so then with like, for me, I did the MDMA session with people related to the trial in the same kind of protocol. And I had, things I wanted to, well, I kind of know what my issues are by this point in the ayahuasca, like so many times. I kind of know what's going to come up. And so it's like, I talked to them beforehand about all that. And that's what they do. They for the MDMA trial, they have multiple sessions before the first session. I think they have 3 therapy sessions beforehand where they're getting to know them and trying to understand what might come up and how they're going to deal with it. And so then the MDMA, for me, with them there, yeah, it was really powerful. Like that was another big element. Like I've done it by myself since then because I had such a huge experience with that, with the therapy. And it wasn't the same. Like I got to like 1 or 2 things, but with people there, it just brought up like layers and layers and layers and layers for me, you know. And I did have the experience. They're all asking me, like as an ayahuasca practitioner, well, does MDMA, do you think it has an intelligence? Does it have a spirit? Or and everyone wants to ask that question. And for me, yes, like I've taken some of our community, indigenous healers, Navajo, through it, and they're like really blown away by what it brings forward. And it does have its root in originally in sassafras trees from North America. It was a tradition. The sassafras tree, they're using the root, the saffron oil from the root is from, northern Native America, like the deciduous forests out there, a variety of tribes. So they were the ones that turned on the Westerners to, hey, you can use this. And then that was sassafras, right, for the root beer. But then, MDMA is just a step away from that. And so it's a medicinal plant and tree in tradition. But the isolated chemical, it's a little different, and they have different sources now. But I did have an experience like that. It was, so for me, for us at ayahuasca, people, more than a lot of things, they do experience dialogue. It's one of the unique aspects of it, and it's people from all walks of life. that don't think, they don't believe in anything, and then they find themselves, it's like, well, then was it me? Is it my higher self, or who am I talking to, or what? It's like, well, who knows? Nobody knows actually. So the point is like you're just dialogue to get somewhere, to progress.
In regards to that dialogue, this is something else that Dr. Rick Strassman was talking about a bit yesterday, about the concept of the prophetic mystical experience, where there's a reception of information, there's access to knowledge, and there's actually a strengthening of the ego, where you are totally aware of yourself completely, and you're receiving information and communication. How do you advise participants on how to weigh communications like this? Should they be taken as more or less valuable than everyday thoughts?
Yeah, you have to take it slow, with stuff like that.
Mm-hmm.
So it's like ayahuasca tells me, Joe, it's the epigenetics. Look there, you know. It told Rachel Harris, who's a long-term academic faculty, University of Miami, psychology professor, but she's like still semi-agnostic, right? Like she's just like, is this real? And so they told her, do this study. You're going to do this study. And then when it got towards the end, they said, I'm going to tell you how it's going to turn out. It's like, it's not going to be that ayahuasca retreats is better than, it's just going to be about the same as the Catholic retreat. But that's all we need. That's why you're doing it. And so, like, things like that, Some other people get, like in Peru for a little while, there was a famous, when I first started going down there was a guy building a pyramid on the river, like a pyramid out of wood with a huge army of workers, huge, and kind of like a little bit ridiculous. Like, I think that's the first response of most people, like, what
Yeah.
is that? It's like, well, ayahuasca told me to do it. And so everyone's like, "Mm." It's like, you need, so you have to, another big one, like for example, and this isn't as prophetic, but like, let's say you on like buried sexual abuse. Then people have this experience of, oh my God, like this was like, was this a repressed memory? And it's like, okay, well, we don't know yet. Like we got to figure that out. We got to work with that. Some things there, some energies crossed. So let's not jump to that conclusion.
Mm-hmm.
So then you don't want to jump to conclusions. You want to take your time, and that's what the integration process is about. And then one thing I'll throw out there along those lines is something that the worker that my friend Sochi here in Colombia, one of the elders was like, okay, cat's out of the bag. You guys are drinking ayahuasca up there. And so we feel like we need to give you some guidance. So one of the first guidance points he said is, if this is making you feel better than or more than the rest and everything else, like, it's not working. So this should be making you feel more integral to the whole.
Mm-hmm.
So that's a way to measure a little bit of what's going on. Because people do get either manic or just very egoic or very narcissistic, with their messiah complex from what they experienced. And so it's like, okay, well, they're saying that's not it. That's not the medicine. That's not the message. You need to figure out how that's going to help you become part of the whole.
Beautiful. This next question has also kind of been a subject that's come up throughout the conference, and I'll phrase it this way. What are your thoughts on the concept of adverse events versus the concept of a challenging experience during a psychedelic trip? Are the anxieties and fears that come up harm to the patient, or is that part, maybe not integral, but is that just an accepted part of the experience that should not be criticized or suppressed?
Yeah, and for us, it's part of the experience. So then you want to be gentle with people. You want to, like, you don't need to over push people. So when I was at the MDMA, so that's the thing, you don't need, some people are like, hey, you must, go big or go home, and they want to do heroic dose,
Mm-hmm.
But they don't know why. Like, why are they doing that? And so for us, it's like you dose up as to what you can tolerate, that's first. Like that's how we do it. People drink ayahuasca with our group like 6 times in 10 days. And so there's a lot of room there to adjust their dose. Even then, it might sneak up on them, you know? They might get a lot more than they bargained for and than they feel ready for, you know? And that might be difficult, you know? That might be a hellish experience. That might be a fearful experience. That might be, you know, trauma coming up. That might be remembering when you wanted to commit suicide and just stuck in thoughts of, I'm going to kill myself, you know? And so
Mhm.
for us, that's there's dose related concerns. Like, okay, are you ready for that? That's one thought. The other thought is like, is the container ready for you to hold you through that? Because like for us, they're gonna throw up, you know, and have diarrhea and then go, well, you know, like I don't know what Rick says, but it's like they're just like, oh, just DMT and then you don't have to throw up. And you know, it's because the Indians, they don't know how to make DMT. They're stuck with this primitive form. And it's like, well, ayahuasca is not a DMT delivery device. You know, that's not the tradition. They don't, that's their experience from however thousands of years is what we know so far from the archaeology. It's like the purgative nature of it is considered extremely healing in the same way that purgatives are used all over the world, whether that's Ayurveda or South African traditional medicine. So, and then the challenging experiences that, you know, there's a lot of concern about them being, you know, re-traumatizing the person. And so then Marcela Otalada, who's one of the MAPS trainers, you know, we were at some event together. And so she said, well, in her experience, because they guide people through that kind of thing, you know, like it's not going to be necessarily pleasant to work out some of this stuff. You know, they're just like,
Mhm.
the attitude down there is like, well, aren't you suffering right now? Like, you don't, like, I thought it was pretty bad right now. So
Mhm.
it's like, yeah, I guess when we rip the band-aid off, like, yeah, I guess, yeah, it might sting a little bit. So then the question is that Marcella brings up is she says in her experience of people that have been said to be re-traumatized and then they come into her practice from a previous, let's say, MDMA or psychedelic trip, and they come into her practice. She said, this was her words, she felt like in her experience that was really a symptom of the practitioner not being ready to go there. But if the
Mhm.
practitioner is ready to go wherever we need to go and be there with them through that, then they were going to come through it. And that was her experience. And that's my experience in ayahuasca down there.
Wow.
People really have intense experiences sometimes down there. And it can be traumatic. I'm not saying it's never traumatic, but most of the time, in my experience anywhere now, if you can carry the person through it and you know how to go where they need to go, then they do come through something. You know, that being said, you don't have to push them that hard. You know, you don't need to push them that hard. Let them, you know, work through it. I think there's a lot of room for a more gentle approach.
A fantastic response. Um, we just have time for a few more questions, so I guess we'll try to do these ones rapid fire. It's some great questions here. Can you
My hot
comment
seat.
on yeah? Can you comment on medicines that may be used in conjunction with Aya during ceremonies such as rape or mapacho or sananga, and their roles in integrating or enhancing the conscious experience?
I think that's very dependent on the different traditions. So, like Shipibo tradition that I work with, they smoke mapacho in ceremony. It's tobacco. It's a Peruvian Amazonian tobacco. And so you smoke that, and it's considered a master plant tobacco, just like in Northern Native America. It's considered a spiritual teacher, an assistant, and a guide to the process to support you, you know, as you go through it for the healer and for the person. In Brazil, hape, you know, it's like a tobacco snuff that they snuff and they do it in the ceremony and afterwards and all over the place. And so that's, you know, a lot of people really get into that. Westerners, Americans love hape and they just, you know, they want to do it all and they think, but, you know, that's in our tradition, they don't do it in the ceremony. So, like when people come, they want to do it at ours. I'm like, well, maybe wait till after, you know, because we don't do that. Because sometimes they have to turn on the flashlight and they're doing their hape. It makes a scene. And then the sananga is what I know what sananga is. My experience is the Brazilian, like it's like a thing you put in your eyes, right? That burns like broken glass. It's supposed to help your vision, and I've done it a couple times. I've never done it in ayahuasca ceremony. I don't know. I never heard that they do it in ayahuasca ceremony down there, you know. So then there's also like this fear factor American culture that just wants to, you know. And then what happens if you, you know, stab my
Yes.
hand right at the moment, you know, then I'm gonna
Yes.
become enlightened, you know, or could I, somebody give me $1 million if I, you know, shove all this stuff in my face? It's like, why? You know, that's my question. It's like,
It does almost
so
sound
I'm
like,
saying there's room for each one, and I think what's be interesting to me is to learn from the tradition because they have the experience.
hmm
So one of the issues that happened was in Florida at one of those places, the healing center, giving combo like the frog poison, right? That you put on your arm. I don't know if you heard about that one. There's another one in the Amazon. So you put the combo frog poison, and so there it can cause electrolyte disturbances, like it can cause hyponatremia, like low salt. And so then they were doing like they were doing ayahuasca like day and night for 3 days, and then the morning combo. And a kid who had, it turns out he had an undisclosed seizure disorder he didn't tell them about, but he went into seizure and was hyponatremic and he died. You know, that kid died. So when they asked me and they were talking to me, I'm like, well, where did you like think that it was okay to do that? Like from what body of experience are you going to say, okay, 3 days in a row and then combo in the morning? So you can lean on that and say, well, this has actually been safe like over and over again. So this is a freak event. But that's not the case. Like you guys just threw that combo on him on the morning just because you just, you know, to squeeze it into the weekend. And so that's my thing is like experience teaches wisdom. So the reason that we learn from them is just because maybe something bad happened before. So that's what we're trying to figure out. Just like a doctor, you know, if everybody's a doctor, or there's a lot of people, not everyone here, but a lot of people are trying to become physicians of different kinds. It's like, yeah, you have to kind of learn from what happened before, you know, so you don't injure people from prior experience. So that's my thought on that. It's like, okay, mix and match, you know, but it'd be nice if you could lean on something. I know there's innovation. I know there are cultures are mixing. We're opening up new territory, but you know, be careful, you know. And if it's just because you want to like whatever, like I said, freak out like you're on TV, well, that's not a good enough reason, you know.
Absolutely. This last question is quite lovely. I would love to support the center. This is your center. If you have a website where you sell Shipibo altar cloths or other offerings, it seems like a lot of people really just want to support your work in any way
Right.
possible.
Oh, that's great. No, the center knew it out. I'm no longer a business partner. We Ricardo, you know, we sold our shares to Ricardo, so now the Shipibo healer is the owner, and so we still go there, but it's him. You know, it's his business, it's his tradition. So we just go there, and they sell stuff. They're not like online. There are people that do sell online Shipibo stuff, but the locals there are not. And so I don't have a good, you know, one for that. There were a lot of people gave a lot of donations to help them through the pandemic, but they made it and now they're functioning, so they're okay. Um, Going there is one way you're sending people there. And then for us, like yeah, for my work, modernspirit.org is one thing. It's a nonprofit, and so we take money. And so for this reciprocity project, for the epigenetics project, for our work in Colombia here to try to build these messages and spread the messages up north, translating them to English. So that's through Modern Spirit. The Church of the Eagle and the Condor is going through a legal process right now, trying to get ayahuasca legal for us, and that's a big deal. You know, negotiating with the DEA. So they're also, you know, we don't have an active campaign for money right now, but we did in the past. So those are different ways to support. That's me. Shipibo support. There's a lot of ways. Temple of the Way of Light has templeofthewayoflight.org. They have a few projects that are directly supporting Shipibo communities down there. I think Ayahuasca Foundation might also have something. Anyway, it is Shipibo's. They're just running it, so they're on their own. Come see them and they'll take money from you there.
Wonderful. So if you think of any other organizations that we can get in touch with and help support, please just send those to us later. And I think we'll transition to the next part of the conference. Dr. Tafur, I cannot thank you enough. That was so wonderful and heartfelt and enlightening. Thank you so much.
Yeah, thank you, everybody. Thank you. A lot of fun to be with you. All the best.
Wonderful. Thank you.
All right. Bye-bye.
Adios.
Adios.
All right, everyone. So I am Magdalene Lederer, one of the organizers here, and we are now transitioning to our poster session. Very exciting. So we are going to post a link in the chat so you can see the posters up close if you can't see them super well on our screen. We're also going to share the slides. First, we're going to introduce our first speaker. Student Dr. Taylor Limone will be presenting this presentation, and then student Dr. Victoria Murray will be answering for the Q&A portion. If you have any questions, throw them in the chat. We will read them out to the presenters. We really want to be this as interactive as possible to make it really feel like an in-person poster session. So a little bit about student Dr. Taylor Limone. She's a second year here at Rowan School of Osteopathic Medicine. She is from Burlington Township, New Jersey, and attended the University of Scranton, graduated in 2020 with a Bachelor of Science in Biochem and in Philosophy. Today, Taylor will be presenting a literature review about the use of esketamine for treatment-resistant depression in the elderly. All right, Taylor, we'll share the slides for you and you can take it on over.
Perfect, thank you. If it's not sharing, I can pull it up if you want me to.
We have it. We're just taking a second to pull it up. Please use the link that Ayesha here put in the chat in case you want to see it for yourself also, and start to think of new questions for our presenters. Thank you, everyone. Taylor, you can go ahead and start sharing if that works for you. We're having some trouble on our end.
Can everybody see it okay? Perfect. All right. So thank you so much for that introduction. I want to greet everybody who's here and really welcome you for today's poster session. I'm so honored that everybody's here to listen to what all the presenters have to say today. I'm very excited to be a part of this. Over the last few months, I've had the honor of working alongside some of my peers here at Rowan University School of Osteopathic Medicine, as well as a student at Cooper Medical School under the guidance of Dr. Mitchell A. Kling on a poster about the use of esketamine for treatment-resistant depression in the elderly. We've heard some phenomenal presentations about ketamine so far, so I'm really looking forward to be able to add to and enrich some of your things that you've learned and maybe have you consider its use in the elderly. So while we're speaking about elderly populations, throughout this discussion, I want you to consider someone who's elderly to be older than 65. And these elderly groups have been suggested to have a prevalence of depression of approaching 11.2%. Treatment-resistant depression has also been documented within elderly populations. While pinpointing an exact definition of treatment-resistant depression has proven difficult, there's some general terms that are found throughout every definition of treatment-resistant depression, or most of them, and that would include failure to improve following an adequate trial of at least 2 therapeutics of a sufficient dosage during a depressive episode. Now, there are other therapeutics, other treatments that are used for treatment-resistant depression, but one of those promising ones is ketamine, or in the case of our literature review, we're looking at ketamine's S enantiomer, esketamine, and this has been suggested for use in treatment-resistant depression. The drug ketamine has been historically used as an anesthetic, so you may be familiar with it from that or from the presentations that we heard throughout this conference. But ketamine is classified as a non-barbiturate dissociative anesthetic, and it acts as an antagonist at the N-methyl D-aspartate receptor, or more simply put, the NMDA receptor. Ketamine can be dosed intravenously among many other modes of delivery, but it can also be dosed intranasally. And the therapeutic Spravato recently received approval from by Janssen. And the intranasal bioavailability is less than that of intravenous. Intravenous usually approaches about 100% bioavailable, but for intranasal, it's estimated anywhere between 8 and 45% bioavailable. which we discussed sort of early in the earlier ketamine presentations. Ketamine has been hypothesized to have a few different mechanisms of action, just from blocking the NMDA receptor to preventing anti-inflammatory actions or inducing brain-derived neurotropic factor, and even an inhibition of the specific subunit of that NMDA receptor. Now, moving into how we sort of conducted this literature review, what we did was we looked all across the internet on PubMed, Google Scholar, and as well as clinicaltrials.gov. And the bulk of the data that we collected were published in 2016 to 2021. So really recent studies. We found 14 total studies that were evaluated within, and we included studies that evaluated safety, efficacy, and outcomes of the use of esketamine as a possible therapeutic for TRD. Studies were not excluded if participants were younger than 65 years old, as the inclusion of these studies really enriched our perspective of those safety, the efficacy of it, as well as the outcomes of using esketamine. It should be noted that of the 14 studies that were included, less than 265 participants enrolled were actually older than 65 years old. And that's compared to the over 3,000 participants enrolled in total. So there's not a lot of research on using ketamine in the elderly for treatment-resistant depression. Now, as for trends of these 14 studies, within this literature review, it suggested that ketamine can be a useful therapeutic for treatment-resistant depression. 2 studies by Popova et al. And Ionesco et al. Used the Montgomery-Åsberg Depression Rating Scale to measure if treatment with esketamine could result in a reduction of a depressive episode. Both studies were double-blind and randomized and actually reported a reduced score in the treatment groups, which seems to support using ketamine for treatment-resistant depression. As we also discussed yesterday in a presentation by student Dr. Magdalene Lederer on psychedelics and eating disorders, we talked a little bit about the use of ketamine and possibly its reduction in suicidality. The Aspire 2 study, which is that Ionesco et al. Study, also looked at suicidality through the scoring of the Clinical Global Impression Severity of Suicidality Revised Score. And this compared 2 treatment arms. So the first treatment arm was a intranasal dose, 84 milligrams of ketamine twice a week for 4 weeks, plus an antidepressant, compared to a placebo intranasal spray plus an antidepressant. Now, both of these arms did show decreased suicidality, but there was no statistically different number between the 2 groups. In terms of safety, the most common side effects that were reported included dizziness, headache, nausea, as well as a transient dissociation, all of which were discussed earlier. While these studies do offer insight to the potential use of esketamine for treatment-resistant depression, only 3 of the 14 studies actually included patients older than 65, which really highlights the need for more exploration of the safety and efficacy of esketamine in this population. As was brought up yesterday in student Dr. Zerpa's presentation on the use of ketamine in the agitated patient, a discussion came up about the safety and use of ketamine in elderly populations. Elderly populations do require a more in-depth review of all safety and efficacy considerations, especially regarding ketamine. The elderly have been found to have a decreased response of the NMDA receptor system, or you can think of it sort of as hypofunctional as you age. So that may have implications on dosing for esketamine in the elderly population. Ketamine was also found to be associated with transient increases in blood pressure. So we discussed that a little bit in this morning's presentation. You might not want to give it to someone with uncontrolled hypertension. The dizziness associated with the initial dose of ketamine may have implications for fall risk in the elderly. So you really want to watch patients following an immediate dosage. Additionally, ketamine is metabolized by cytochrome P450. So it's the isoforms 3A4 and 2B6, among other isoforms. But this is associated with drug-drug interactions. So drugs like diazepam, rifampin, clarithromycin, ethosuximide, morphine, and St. John's wort. And all of these considerations sort of compounded really do weigh heavily on the use of esketamine in the elderly and almost necessitate more research on the population to really elucidate these considerations. Now, according to some studies, the elderly have been estimated to have a prevalence of treatment-resistant depression approaching 30.9%. So that's a really high number. But the safety, efficacy, and outcomes of esketamine within elderly populations has been sparingly researched. As previously mentioned, The side effects within elderly populations suggest the need for research within this population. And the cost of esketamine as a therapeutic can actually be quite expensive, approaching almost $39,400 yearly. And this is sometimes not covered by certain insurances, including Medicare and Medicaid. However, since esketamine may provide benefits for treatment-resistant depression within the elderly population, more research is needed into the use of esketamine alone or in combination with other therapeutics for treatment-resistant depression. So that sort of concludes this little talk about the literature review that we all worked on. I would like to thank you all for your attention today. All of the references that I used within this poster can be found by scanning the QR code below. That also includes all the references I used in this talk. I would also like to take a quick moment to thank all the organizers of this conference. They did a wonderful job making sure everything runs smoothly and really built such an informative conference for all of us. I know I've learned so much. So I wanted to thank you all, and I want to open up for questions.
Wow, Taylor, thank you so much for that presentation. I don't think we've seen any questions come in the chat. We don't have any right now, but if you would be able to stick around for the next few minutes in case anyone comes in and you can type them in, that would be fabulous. Awesome, great. So now we're going to transition to our next speaker. Our next speaker is Dr. Rida Khan. She's in the MD class of 2022 at Al Faisal, I'm not saying that right, University College of Medicine. Her interests include community psychiatry and crisis care and academic psychiatry. She's coming to us today to present on psychedelic research and personality disorders. Welcome, Rida. So glad to have you here.
Guys, hi everyone.
Hi.
How are you guys? Thank you so much for having me. Thank you for arranging this conference. Certainly learning a lot, and the speakers have all been excellent. So I'm going to present on personality disorders in psychedelic research, or psychedelic research and personality disorders. Actually, I'm glad my poster is towards the end because now we know what psychedelics are all about, so I don't actually need to sell those to you. I can probably emphasize personality disorders and how psychedelic research can possibly be useful to patients suffering or living with personality disorders. Personality disorders are interesting. You can conceptualize them more as neurodevelopmental syndromes more than anything, and this is psychiatry now, because thank you for pulling up my poster. I didn't even realize that it wasn't up there. Psychiatry, personality disorders, they can be conceptualized as more like neurodevelopmental syndromes where the person's own personal brain chemistry does not match with their childhood environment, which leads to a constellation of symptoms in adulthood that is problematic, to say the least. Personality disorders are not exactly a disputed construct, but I think, or at least from what I've gathered over the years of medical school and psychiatry and all of that, is that I think there is active debate into the utility of those constructs, more so than in any other psychiatric diagnostic, like any other psychiatric diagnoses. But the truth is, at the end of the day, that the patients who come to you with personality disorders are real and they're struggling, and it's important not to neglect them. They're often the problem patient or the difficult patient, and they don't necessarily present with a personality disorder. They mostly, for instance, taking narcissistic personality disorder, it most commonly presents with depression and substance use disorder. Borderline personality disorder most commonly presents with basically everything. So depression, anxiety, substance use, suicidality, eating disorders, and all of that. So the state of psychedelic research in psychiatry, and this has been covered today and was covered yesterday as well, that studies are mostly studying treatment-resistant depression. They're studying anxiety and end-stage illness. There have been studies on substance use disorders, including alcohol and tobacco. No studies have been done on personality disorder subjects. There is an excellent review out there that was published last year on psychedelic research in borderline personality disorder, and it looked into a number of randomized controlled trials or studies which actively administer psychedelic substances, and it looked through the enrolled subjects to see which subjects tick the boxes for borderline personality disorder diagnostic criteria. And interestingly, there were a few. And currently, right now, there is one study at Yale being conducted with patients with borderline personality disorder, but only in the context of suicidality, which we already know that there is evidence for using ketamine for suicidality in general. So I looked into psychedelic research, which was non-existent, as I just said, and then I expanded the search to look into just personality in general. And some things did come up, but they were pretty random. So they listed things in personality like openness or agreeableness. Other than that, there was no standardization of personality measures in these studies, although they were mentioned. So I decided to include them nonetheless because I thought that those would be relevant. And I think really the problem of lack of standardized assessment tools is a problem probably that plagues all of psychiatry in general. It just becomes more annoying when it comes to personality disorders because that is really the only measure by which you can measure the illness, the presence of the illness. So I further expanded the search to include DSM-5 correlates for personality disorders, narcissistic personality disorder and borderline personality disorder. I looked into comorbidities like depression, anxiety, substance use, and suicidality. So that's for the methods, and I'm going to read out the results. If you could scroll up a little just to the results section, which is that no studies recently have been done to study potential therapeutic effects of psychedelic substances in personality disorder subjects. Studies have found, and this is the important part, that psychedelic substances alter consciousness and induce positive changes in insightfulness, mindfulness, and emotion regulation capacity. Studies have found that psychedelic substances decrease depression, anxiety, impulsivity, obsessive compulsive anxiety, substance use behaviors, including tobacco and alcohol, and suicidality. These studies were not uniformly, I should have removed that word from the poster, but they were conducted with psychotherapy administered as an adjunct to the psychedelic substance administration. The thing with personality disorders currently is that the treatment of choice is psychotherapy, and it's long-term psychotherapy. So it's not just a month or two of psychotherapy, but several months, if not at least a year, with adding psychedelic substance as an adjunct to that psychotherapy. Looking at these results, it is possible that that might be more effective and bringing about faster symptom relief, possibly. But of course, all of this still needs to be studied. For instance, with like a randomized controlled trial where half the patients get psilocybin and half get nothing, and they both get psychotherapy or DBT for 6 months. An important thing to note here is that emotion regulation capacity was increased, and BPD is conceptualized as the disease of emotion dysregulation. Mindfulness also is a part of the psychedelic substance use experience, so to speak. And DBT, which is the treatment of choice for borderline personality disorder, is very much based on mindfulness as well. So that was the hypothesis. The hypothesis was that are psychedelics useful for patients struggling with personality disorder? The answer is we don't know, maybe, possibly. It's very interesting and we should look into it, not just because it's interesting, but also because of the immense potential to help people. And yeah, we've identified probably an area of strong interest for future psychedelic research. I'll just conclude by acknowledging Rebecca, who runs Borderliner Notes, which puts out information about borderline personality disorder, and it was really her idea to look into it.
Wow, Rita, thank you so much for this presentation. Identifying gaps in research is huge. I mean, like you said, the only option we have for people with borderline with personality disorders is often just therapy, which is great. But if that's our only solution and it's something you have to do for decades, I feel like that is what continues to drop out and people not following up with care. So I love that you really highlighted an area where there is a need for further research, and psychedelics could be part of the solution for people suffering from these disorders. Does anyone, I haven't seen any in the chat, if you have a question, please throw it in there. Rita will type a response. But we want to thank you so much for coming today, Rita, especially from where you are.
Yeah, it's 12 a.m.
Yes, so quickly, we'll end so you can go to bed, I promise. All right, so we'll stop sharing this. Thank you so much. Our last presentation of the day, wow, what a weekend. Our last presentation of the day will be from Omar Qari. He's a third-year medical student from Cooper Medical School of Rowan University, so just about half hour from us right now. He intends to pursue a career in psychiatry. Within the field, Omar is active in research spanning different areas such as management for acute agitation, the potential of psychedelic-assisted psychotherapy, and the intersection of psychiatry and the juvenile justice system and how it pertains to rehabilitating offending youths. In his free time, which doesn't sound like he has a lot, he's very busy, Omar loves to learn how to produce electronic dance music, study world geography, and avidly follow the world of European soccer. Omar, thank you so much for being here today.
Well, thanks so much for having me, everyone. This weekend has been hugely educational on a topic that we really don't get to learn about in medical school unless we seek it out. So, it's just happy to be here, and thanks to the organizers for putting this together.
Awesome. So we're going to share your poster. Here we go. And you have the floor.
Sure. So, when I was thinking about a topic submission, I really noticed that among what we call the classical psychedelics, mescaline is a compound that, in recent years and recent decades kind of dropped in terms of how much research was happening around it. But, just looking at its importance historically, mescaline has been always around and always in conversation. So I decided to make this poster, called the Biopsychosocial Framework, and just applying it to what we understand to mescaline. Because, a lot of the research I did, and this is a narrative review, so I was looking at a lot of papers, and a lot of them were either during the periods of the 60s to late 70s, and then you just saw a sudden scarcity. And then you saw some more research popping up once the 2000s rolled around. And the reason why I wanted to kind of use a biopsychosocial framework is because for a psychedelic compound that not many of us are aware of, it's sometimes helpful to just organize things in three separate buckets. I know yesterday during Jesse's presentation, he was talking about the mind, body, spirit, and I think that's a great that's also a great system as well. And I was thinking, maybe I should have gone with that. So with that said, what I found, given the research available on mescaline, I first wanted to just talk about the background a bit. And I think things that people sometimes confuse about mescaline, although we've had some talks already this weekend on it, is that mescaline is referring to the the psychoactive compound within cactuses such as the San Pedro cactus or the peyote cactus. So the compound mescaline could appear in several plants and several herbs. And the other thing I want to emphasize about peyote, which contains mescaline and is popularly used in North American culture, is that this compound has only been heavily used by the indigenous people of the United States, Mexico, and Canada. And there is an extensive history there of this population using what we call, mescaline, and they've used it for thousands of years, almost to the point where the words they use for medicine actually consist of their reference towards peyote. And it's important in how Western medicine approaches this entire compound with an understanding that a certain group of people have a very extensive history with this substance, and there's knowledge and wisdom to be gained from that. So with that said, the peyote cactus, also scientifically known as Lepophora williamsi, it's been used in sacred ceremonies by numerous Native Indian tribes throughout the United States, but primarily in the southwestern region as well as northern Mexico. And because of that, if anyone decides to look at cultural depictions of a cactus like peyote, which contains mescaline, you see that it's is deeply intertwined with the art as well as the medical aspects of a given society there. Also important to note is that obviously in the United States, mescaline has received a Schedule 1, classification according to the DEA by way of the Comprehensive Drug Abuse Prevention and Control Act. And because of that, you see that's a huge reason why there's a scarcity of research, as well as just more bureaucratic barriers and understanding how we could use this better in a Western medicine framework. So, as I mentioned earlier, this is this is a narrative review, and I looked at about and read through about over 40 papers, and through that understanding, I was kind of sorting things out into what points I'd want to convey to a general audience. And moving and looking at that table in the center of just a biological understanding and application. First things first. There's a chemical name, but the compound mescaline belongs to the phenylethylamines group, and there are structural similarities that exist between mescaline and amphetamines, epinephrine, and norepinephrine. And a lot of the research I was looking at was actually chemistry research, just deciding how they're going to classify this, and then what that classification brings in terms of physiological understanding of its effects. It's the physiological effects of mescaline are largely sympathomimetic. You see an uptick in heart rate and blood pressure, pupil dilation, perspiration, and then the other distinguishing side effect, because it's not as pleasant, is that usually there's a side effect of nausea and indigestion. So the primary route of intake for mescaline is usually through ingesting the actual cactus, whether that be the San Pedro cactus or the peyote cactus. You're usually eating cactus buttons, basically. They're small slices of the cactus, and each peyote button contains about 45 milligrams of mescaline. But you need about 200 to 500 to feel something. So as you can imagine, you're expected to probably eat, if you want to have a proper experience with mescaline, and you're eating these peyote buttons, you're probably going to be eating about 10. So it's a very laborious task, and because of that, and because of the other chemical compounds that also exist in the peyote cactus, there is a very common observation of nausea and vomiting being felt. Although some would call it an adverse effect, others find meaning in that as well, in terms of how it fits into their entire trip with that peyote cactus. As far as the neuropharmacology of mescaline goes, it's theorized currently that there's a lot of action with mescaline on the serotonin 2A 2C receptors, and when we think about how a psychoactive substance like mescaline causes hallucinations, it's we're mainly looking at this pathway here, and how it's interacting with areas of our brain such as the locus coeruleus and the cerebral cortex. And we do know that with this activation, you do see a neuronal release of neurotransmitters such as glutamate or norepinephrine. And then moving on to the psychological understanding and application, and I think this is where a lot of the emphasis should be placed, because throughout this weekend we've realized that the average person is taking a psychedelic substance for really this reason: the psychological understanding and application. And with that said, there's a lot of themes that kind of pervade across different psychedelic substances. So like mescaline, psilocybin, LSD, they'll have similar effects. You'll see similarities in between them, but you'll also see some distinguishing characteristics. So subjective accounts, they vary widely, but you hear themes of euphoria, lethargy, fright, paranoia. But then going back to that entire idea of the set and setting really determining the outcome of whatever you're embarking on by ingesting a certain substance. And I've also included a nice diagram in that column of a traditional depiction, a woven depiction of the peyote cactus by members of the Huichol tribe, they primarily reside in northern Mexico, and in fact, that's where a lot of peyote cactus grows. And in their culture and religion, they have an entire practice of a migration to areas with fertile peyote cactus growth, where they yearly embark on some significant experiences through that. And then on my readings of subjective accounts of the peyote cactus, yesterday some NJMS students had a great talk about it, and I saw those people categorize a mescaline trip in two parts. The first phase, lasting about an hour, and really identified by the nausea and vomiting that people experience, and that's usually not the pleasant portion of the trip. But depending on the user, there is sometimes a meaning or interpretation even attached to that first phase to get to the second. So you get to that second phase, and this is really where the psychoactive component of mescaline really takes a hold. And there's auditory and visual hallucinations experience. And as far as the visual hallucinations go, you see not only do you see the geometricization of certain things, but you also see very unusual patterns appear as well in your periphery, in your visual periphery. And as far as thoughts go, so similar to many other psychedelic compounds, there have been recorded observations of feelings of depersonalization taking place, where certain limbs might feel alien to you all of a sudden during a trip, and you're kind of existing outside your body. There's also disorganized thought patterns, altered sense of time and space, and there's also a difficulty communicating with others, which was interesting to note, specifically in the context of mescaline and psychotherapy. I went down that rabbit hole. It was a pretty short one, mainly because a lot of users prefer not to talk. They're usually dealing with something else. And furthermore, mescaline, given the importance it has to indigenous communities in Northern America as a medicine, it also offers some opportunity for some transcendent spiritual experiences. And this may not look identical across the board for all users of mescaline, but for those who have an understanding of communicating with a deity, this is often a time where they have a very impactful or meaningful experience doing so. And lastly, novel emotional reactions to very ordinary things is also common in a mescaline trip. And moving over to that third column, where it's the social cultural understanding, and I'd love to add the word spiritual here too. But starting off, looking at the history of mescaline. So as I mentioned, it's been used for thousands of years, but it was isolated and identified in 1897. It was synthesized in 1919, and this was and given that time period, a lot of people were trying to figure out how they could use it, in a wartime situation, and is used for often malicious purposes. And it's important to note that people can mishandle the application of a psychedelic. As you can see, in Nazi Germany, it was used, as well as the U.S. government was kind of looking at it in terms of hostage situations and in terms of interrogating prisoners. And then furthermore, the majority of Native American people who use peyote, they strongly believe that it has significant healing power and that it could cure illness. And I mean illness in terms of physical ailments, such as an infection or a fever or an upset stomach. These communities really believe that in their conception of what health is, that taking this wards off evil spirits that cause certain diseases to manifest. And keeping this in mind, as the United States started to crack down further on the usage of mescaline among its indigenous populations, that's around the time where the Native American community kind of banded together across tribes to kind of preserve their right to use this medicine. And that's around the time in 1920 where peyotism, or the Native American Church, was founded by Quanah Parker, a notable Native American chieftain who had a very impactful experience on this substance, and vehemently defended the community's right, and was able to carve out a space in the midst of all this Schedule I discussion to keep the ability for his community to continue using this the way they have been for hundreds of years. So with those exemptions came a lot of opportunity for not only other Native American tribes outside of the Southwest, but also American citizens who identify with the tenets of the Native American Church to enter the folds of using peyote. And for the record, it's illegal to buy, sell, or trade peyote cactus because they contain mescaline, but it's not illegal to cultivate or grow it. So the way the U.S. kind of works around that is that mainly in Texas is where it grows, if we're talking the U.S., and they have registered suppliers of peyote with the state of Texas, and they're called peyoteros. And because of that, they're able to kind of keep track of it, but it grows everywhere in that area. But it should be emphasized that the usage should primarily go to the indigenous communities who rely on it. And the reason I say that is because contemporary efforts have been made across the U.S. to decriminalize not only marijuana, but now the discussion is reaching more psychedelic substances such as magic mushrooms, and peyote cactus makes it into the conversation. So 2 years ago in Santa Barbara, California, a city ordinance was passed to decriminalize psychedelic plants, including the peyote cactus. And this actually prompted a rebuttal from the Native American Church, who weighed in saying that if you legalize this and make it allowed wider access, the quantities of peyote aren't going to change overnight, and this is actually going to take away from our ability to use it as a medicine, which I found a very striking discussion. That this is absolutely the social cultural consideration behind legalizing this substance in particular. That if you allow wider access, then the people who have had a right to it for forever kind of lose that. And it's worth mentioning that mescaline has been synthesized on its own, and there have been a lot of companies taking a shot at seeing how mescaline can further development in terms of treating psychiatric diagnoses. And last but not least, I think a lot of research is now being done in whether or not taking mescaline or taking it often has any long-term psychological effects, whether it has cross-tolerance with similar psychedelics such as psilocybin or LSD. The research I saw, it did suggest that there is some cross-tolerance there. However, experts kind of agree that psychedelics don't elicit addictive behavior in the sense that we see in opioid use, for example. There is a discussion around hallucinogen persisting perception disorder. I remember yesterday there was a talk about that, and it's observed in some people who use mescaline as well, although the numbers are kind of unclear there. And I think another thing worth mentioning, and I think Dr. Strassman said this well, is that we shouldn't call a bad trip a challenging aspect of psychedelics. It's an adverse effect in a way, and more research has to be done on how you can minimize adverse effects if we are going to standardize it as a therapy. And then I included this chart. I think it's nice to wrap up the conference with this chart. Given all the substances discussed, this chart kind of lays out kind of relative potency of psilocybin and LSD to mescaline. And as you can tell, psilocybin and LSD are respectively 20 times to 2,000 times stronger than mescaline, and the dosages needed to feel an effect are less. The time to effect onset is similar, but the effect duration is also what sets apart mescaline from psilocybin, for example. If a mescaline trip will take 12 plus hours, and you're going to need to ingest a lot more to feel something. And then flashback occurrence is also something I looked at. And I saw that it was mainly more common in LSD compared to psilocybin or mescaline. And some frontiers in mescaline research as well as psychedelic research in general. I think the reason why there's been a new boom on psychedelic research is because we have more sophisticated tools to kind of conceptualize how we could bring this back into the framework of psychiatry. And it's clear that psychedelics inspire harmony between brain and behavior, individuals and their environments, and then an appreciation for Western and non-Western traditions, especially in the case of mescaline, where there's been hundreds of years of conceptualized ideas on this substance and how it could help a person, and there is some wisdom to be gained there. And lastly, looking at that classification of the Schedule 1 substance does pose a barrier in psychedelic research. So this is kind of what I came up with. I hope that organizing it in these three categories helps understand this introduction to mescaline, and happy to take any questions.
Wow, thank you for that that very comprehensive conversation. I really appreciate that you brought up the sociocultural aspects and how we do have to be careful when we start to mess with indigenous practices. Not that they're strictly only for indigenous people, but we have to protect the way in which they've used it, as you say, like for millennia. We do have a question for you in the chat. Is there any specific reason why mescaline is not talked about as much as other psychedelics? I'm thinking maybe due to average dose potency compared to others.
Yeah, I think from what I understand, average potency is one. Psychedelics in general encounter the handicap of, if you're going to conduct a formal trial on something, you only need 1 to 3 doses to complete an entire trial. And sometimes the realizations that you attain from whatever you're sampling is they could happen weeks after you conclude your study. So so if you're gonna kind of fitting psychedelics into our research framework, the way we do things in biomedical research, it's just LSD, psilocybin, they're a bit quicker. Mescaline, I think mainly because of that there's some alternatives there in similar families that kind of warrant earlier consideration. I don't think mescaline's out of the picture for future research. It's just that along with its effect duration and the issue of using only a single or few doses during treatment, it doesn't make it as financially attractive. And that's not a good reason not to explore it. Sadly, that's just the way research gets funded. So.
Yes, I completely agree and understand your points there. Thank you so much, Omar. You are our last presenter of the day, so thank you so much for all of that. We're so grateful. Thank you for all of our poster presenters. This last session was a great way to see what our medical students are coming up with these days, so thank you. All right, so if you're still here with us, wow, thank you. This has been a very intense and long weekend, but we are just so glad that you all came out to support not just us at Rowan doing this, but to support what's really international and global research into this growing field. Once again, we would like to thank our faculty advisor, Dr. King, and our institutional support from Dean Machichi and Brittany Quintana. We quite literally could not have done this without them. We want to thank you for showing up, for registering, for signing in, for your questions, for your attention. We are just so blown away by the reception we've had this week. I know I've gotten personal messages and the rest of the board has. So we are just so grateful for this inaugural Psychedelic Medicine Conference. We will be sending out a post-conference email with all of the resources that our many speakers have alluded to this weekend and some of their contact information they'd allowed us to send out. Sign in the sheet if you haven't already. We're just so glad that you came out to support us, and we hope that you have a great rest of your weekend for the 6 hours that's left. And with that, have a great evening.